We've got the best of the national faculty lined up for you. So without wasting any more time, I'm going to introduce you to the moderators of the first session. It's my proud privilege to welcome Dr. Raj Shekharan, sir. Welcome, sir. Good morning, sir. And Dr. Shailesh Hargaonkar from Pune, who's the young dynamic surgeon. Over to both of you for the proceedings of the first session.
Thank you, Ankur. I would like to, it's a great privilege for me and Sailesh to be moderating the first session of the ASSICON. As you rightly said, COVID threw a lot of challenges, but also a great number of opportunities. And they say when the going gets tough, the tough gets going. I think this was precisely what happened to ASSI. I should congratulate our President Chabra, Secretary Ajay, and Ankur, Gautam, and the whole team for doing this excellently well. And we have a fantastic team over here. And this has given a great opportunity. As you said, 30 eminent foreign faculties. And how else we could have done other than this being virtual. So we'll start up with something that is very debatable and also of current interest on navigation. Technology is invading spine surgery like anything. And to do this, we have two of the very eminent people who have published a lot, people who have experience maximum on this field, and David and Neil and Masato and Munish, four of our great friends of not just me personally, but for entire India, for ASSICON, for ASSI. Thank you for being with us. And we will start off with the first talk. And David, congratulations for being the opening batsman for ASSI this year. I would invite David to give his talk on navigation in spine deformity, pearls and pitfalls. David, over to you, David.
Thank you. You can go now. Hello, this is Dr. David Pali. Greetings to my friends in India, and may you have a wonderful meeting. I'm sorry I cannot be with you in person and hope that the world returns to a place where we can travel and be together physically again soon. My disclosures. This is my practice. I do pediatric and adult deformities such as this idiopathic scoliosis, this congenital adult scoliosis, severe adult deformity. And I utilize navigation quite a bit. I utilize it to place pedicle screws in very small pedicles, such as in this neuromuscular scoliosis patient. And that with this navigation technology, we use the tap to determine the diameter of a screw that the pedicle will hold. And then we place the screw and check. And oftentimes, about 1% change based on it. Here's an actual case. This is an adolescent idiopathic scoliosis patient. This is real-time video utilizing an overhead camera along with the navigation screen to show you how long this takes us to place the screw. We've identified the start point. I utilize a burr, create a cortical defect. Now I'll take a navigated awl, insert the awl through the pedicle. Typically, we mallet this end. If the pedicles are small and sclerotic, then we'll use a drill. Various people have various preferences for which technique they use, and I think there are many ways that this works well. So from there, we will remove the awl and then place a tap. If your assistant is helpful and docks this in, then it goes a little bit faster. And then we will upsize the tap to judge the maximum screw diameter that we can place. Then the tap is removed. The size of the screw has been given to the tech, who then loads it, and now the screw is placed. And I do like the tactile feedback that comes from placing this by hand. Certainly it can be done by power, but I think there is less tactile feedback. This is that patient. So it took about a minute and a half to place the screw from start to finish on that particular. So why bother? Well, we know that deformity alters normal anatomy, and we put in a lot of screws in these deformity patients. The pediatric patients may have more challenging pedicles, especially in the concavity of the curve, and that if we can avoid a neurologic event, then we certainly want to do that. That the data says that if you place 22 screws in a patient, that you will often have one malpositioned, and that we're also looking for stronger screw purchase as we apply greater forces to these screws, so we need to optimize them, and that I've had a 0 return to OR rate for screw malposition with navigation, but I do reposition somewhere in 1 to 2% of screws in. One of the key understandings is understanding the insertional arc. So in this patient with a previous fusion for scoliosis who had flat back syndrome and needed a revision, we can look at this trajectory is a perfect trajectory through the L1 pedicle through the fusion mass. This is out medial and this is out lateral. That's a fairly narrow window to achieve with other strategies. We know the morphologic distortion that occurs in the pedicles as this is studied and published. We also know that the pedicle morphology varies and that we commonly are placing screws in type C and type D pedicles. So how good is good enough? Is 100% accuracy an achievable goal? And what is an acceptable rate of malposition or complications? And then what amount of OR time or radiation is justified in order to avoid problems? So there have been multiple meta-analyses on this topic. And that when we look at the initial one, this is what drove me to understand this a little bit better. And that if we look at the box plots, we see that navigation improves not just the accuracy, but also the overall spread of accuracy in patients undergoing this technique. And that in looking at pediatric pedicle screws, an SRS group effort analyzed the literature, and it shows that navigation does improve accuracy of placement. Cases. This meta-analysis shows that navigation decreases the screw perforations in the thoracic spine and in the lumbar spine, and that the operative time was no different. Blood loss actually was less with navigation compared to with, and that for every 11 screws placed, it prevents a perforation, and that the clinical implications of these perforations range from inconsequential to catastrophic. In a study out of the Children's Hospital of Pennsylvania, they compared surgeons who used navigation to those who didn't, but all of them did a check spin of their imaging of their pedicle screws at the end of the case, and showed that the rate of screw removal was much lower in the navigated compared to the non-navigated cases. There are a series of potential sources of error in navigation, and this is from my experience rather than from the literature. So all navigation requires some sort of reference frame attachment, and that this can be bumped or dislodged, especially with the passing of surgical instruments. And if the spinous process is not robust, then this makes it difficult. And I found that in my young congenital patients, this is often the case. Intersegmental motion affects the navigation accuracy, and so I try to place my screws first before doing any osteotomies or releases. It is possible to deform the instruments themselves. So we've bent multiple awls. There are system errors, but these are usually pretty rare. And that this can be checked by comparing a known point, such as the tip of a spinous process 2, 3, 4 levels away from the reference frame, and that gives you a accurate assessment of the real versus. We did a study comparing the accuracy of real versus virtual, and it's 31 patients, 240 screws. about 1.5% were revised based on the check spin. It showed that a mean angular difference between virtual and actual was about 2 degrees. So we tried to represent what does a 2-degree variation versus other degrees of variation look like, and 2 degrees in general should probably be pretty acceptable. How about clinical series? Noel Larson looked up our series from the University of Minnesota, and this was our first cohort. So this was our learning curve as well as subsequent patients. So it's about 2,500. We had a 2.5% repositioning rate, greatest in the mid-thoracic spine, and there was no difference between adults and children. But that our data shows when we look at the pedicle size, once the pedicle is smaller than about 4 millimeters, we see that there was an increased rate of screw malposition. Again, our return to OR for this has been 0, in part because we do a check spin. And when I try to find in the literature what is a return to OR rate for malposition screws, it ranges from 0.8 to 4.3%. How about in congenital deformity? Again, Noel looked at our case series, and we had about 14 patients. And that one of the interesting pieces for me, I tend to be a 2.0 screw density, so placing pedicle screws in each available pedicle. And 19% of the time, there was no pedicle present, so it was a 19% dropout rate, and this was not always evident on the plain films. How about percutaneous instrumentation? So our group looked at this comparing open to percutaneous in terms of impingement on the facet, and that what we showed compared to the literature, navigated percutaneous screws had less impingement or facet joint violation compared to non-navigated percutaneous. How about radiation concerns? This is appropriate and real, and that one O-arm spin on standard settings is about 35 seconds of fluoro equivalent, somewhere in that ballpark. There are a lot of other ways to look at it from a radiation physics perspective, but this gives you a overall ballpark sense. So in conclusion, navigation results in more accurate screw placement. There is not evidence that it takes longer, results in increased blood loss, or that it changes complication rates. It does require capital investment, and there is increased radiation exposure to the patient, but probably decreased radiation exposure to the team. So my personal experience in more than 11 years of using it, and it's actually longer than that now, is a 0% return to OR for screw malposition. Our time is, as you saw, about 2 minutes to 3 minutes a screw. If you miss a screw and have to redirect it, it takes a little bit longer, and revision screws take longer than primaries. It's enhanced our institutional ability to accurately place percutaneous screws and has allowed highly reliable iliosacral implant placement. So I just want to show one example of where everything doesn't go perfectly. So AIS case, placed screws on the bottom, the reference frame up, placed screws on the top. And our check spin showed that we did have a medial perforation. This was subsequently redirected, and no neurologic sequelae, and the patient has turned. And here are her first direct. So it's not perfect. I believe in trust but verify. There is increased radiation exposure to the patient and decrease to the team, and you need to do what's right in your hands for your patients. And for me, that's navigation. Thank you very much.
Okay.
Shailesh, go ahead.
Yeah, excellent presentation, Dr. Pauly. I would like to ask about your experience as you're doing it for so many years. One paper by Jung et al. Has mentioned that when you start your navigation and O-arm, there are 60% chances of having some error. In the second phase, it is 40%. And once you become expert, then it is very good. What is your experience about these screws with navigation?
So it does require a commitment to understanding the technology and using it well. So we made a decision when we started using O-arm in the fall of 2006 that we would use it on cases where we didn't really need it, so that when we had cases where we really needed it, that we were used to it and it was just a part of our workflow. So we adapted that as a cultural behavior pattern in our institution, and it became such a routine thing that it wasn't a big disruption to the OR workflow. And so we just sort of do it the same way every time, and with that, we've just not had that challenge. We did go through a learning curve and getting the technology right in terms of having the scrub techs and the navigation person running the navigation unit getting used to our workflow, and that sped up over time. But we also made the decision that we were going to do a check spin to confirm our accuracy. And you can see that we've had a consistent about 1% change in screw position rate throughout our time. And we've not had neurologic sequelae due to screw position. We have the standard neurologic challenges of 3-column osteotomies and big deformity corrections, but we just have been much better in our screw placement. The screws are bigger and longer, and when we're doing scoliosis corrections, we've been able to put a lot more force on the screws. So our experience would not reflect the experience of the study you suggested, and I can't tell you exactly why that is, but we're very comfortable using it. We all sort of use it in the same way, and it's just how we do business now, and it works safely in our hands. So.
Very well said, sir. There is one question in everyone's mind. Whatever the papers are coming up, they are talking about the cortical breaches, and the types which they have mentioned is 0 to 2 millimeter, 2 to 4 millimeter, and more than 4. In routine practice, how much it really matters if it is a 0 to 2% breach?
That is a really, really good question. So that study goes back to Stan Gertzbein and the SRS fracture study in 1990 that was published in Spine. And what Stan said was that in what they looked at, they did not see any sequelae from 2 millimeter screw breaches. This was more of a fracture patient population, much more at the thoracolumbar junction. What I would say is Linke has taught us now the morphologic changes of the spinal cord in the concavity of a scoliotic deformity. And when you have spinal cord shape deformation, any breach can be profoundly problematic. So I think it depends on what the setting is and what you're looking at, and that it depends on what region of the spine. So I think we all want to shoot for 100% accuracy. Some of the time we have violations that are not problematic, but I don't know anyone who wants to have violations, and that if we're going to have a perforation in general, we would prefer that it be lateral to medial. And the biggest danger zone is the apical concavity of a big scoliotic deformity where there isn't much room for error. And so I guess that would be my response, having looked at this over the years. So.
Okay. Yes, Raja sir, what is your experience?
I mean, we, as David said, this is the way we run the business now. I mean, I would be really very uncomfortable in doing any major osteotomies or difficult deformities without navigation. There have also been instances where when we had severe neurofibromatosis and deformities, if there was a hitch in navigation, I would actually postpone the surgery by a week to get that right, because the difference of comfort of operating, your ease of operating, your accuracy is huge when you actually come to difficult deformities. So I think we are actually running late by 5 minutes already, so we should move on to Professor Tanaka. It's been a great pleasure to always know Tanaka. I always get enthused by his enthusiasm, and it's great fun having him in any of the conferences. So Masato, can you please go on with you?
Yes. Thank you. Good morning, dear colleague. It's a great honor for me to attend this wonderful meeting. Today, I'd like to share our knowledge about spinal navigation with you. For MIS, spinal navigation has several advantages, such as less radiation hazard to the staff, no guide wire complication, and we can use 3D image. On the other hand, there are several disadvantages like equipment is very expensive, navigation error, and learning curve. We have ORM. It needs few seconds to take a clean image. Various kinds of navigated instruments and implants are available, like navigated high-speed bar, navigated curve, navigated expandable case. This is the topic of my talk. First, I'll mention about cervical application. This is a conventional use of navigation for Down syndrome. Now you can see the atlantoaxial subluxation. Here is a video. After the exposure, use O-arm. Now I'm putting C2 pedicle screw. C1 lateral mass screw is also inserted under navigation. This is post-op image. Screws were inserted correctly. This is a cervical OPLL case. Now you can see the double layer sign of OPLL. This means a high risk of dural tear. We reported intraoperative O-arm navigation guided OPLL floating technique. There is no reliable structure suitable for reference frame around anterior neck. If you attach the reference frame to Mayfield or table, these are very mobile, so navigation accuracy is not so good. In our technique, we attach the reference frame to the retractor with a special connector. Remove the vertebral body with high-speed burr. Use ultrasonic bone cutter. Finally, OPLL is floating. Let me introduce our new technique, C-arm-free biceps, minimally invasive cervical pedicle screw fixation. This is a postoperative approach to the cervical pedicle. Cervical lordosis enables us a very small skin incision. Just 4 cm paraspinal incision leads the facet joints. Put pedicle screws. Neuromonitoring is preferable for this technique. This is post-op X-rays. These are CAT scans. According to our results, all time and blood loss are less than conventional technique. Next topic is thoracic application. Nowadays, for AIS, posterior procedure is very popular. Why do we need anterior procedure? Because we can save one mobile segment for patient. This case is 13 years old female, Lenke type 5. Let me show you the video. Screw trajectory and lengths are measured on the screen. Then tapping with navigation. No CM needed. Finally, put a screw. In Japan, dual rods technique is very popular. This is a post-op X-rays. Already published. This is the upper thoracic OPLL case. You cannot decompress spinal cord from anteriorly because of the large vessels. For this case, we perform a new technique of posterolateral decompression of OPLL with navigation. Cut the intercostal nerves and elevate the spinal cord gently, then make OPLL floating from posterolateral. We make 2 gutters correctly from posterolateral and make OPLL floating. This patient got the full recovery. The new technique of transdiscal screws for dish fracture. The position of the patient should be lateral, not to open the fracture site. These are post-op X-rays. These are post-op CAT scan. If you use this technique, screw pull-out strength become 1.6 times more than conventional PPS. So, 2 above 2 below fixation is enough, even for dish fracture. This is a revision case of balloon kyphoplasty. Just a small 5 cm skin incision, then remove a rib. Use navigated curve, trial, cage. Expandable cage is also navigated. These are post-op images. Take-home message. Could you remember MICEP's minimally invasive cervical pedicle screw technique? Position of the reference frame is very important. CM-free anterior correction for AIS is a novel technique. Pull-out strength of transdiscal screw is 1.6 times more than conventional screws. Final topic is lumbar application. This is L3 and 4 spondylolisthesis case. We performed a novel MIS technique of simultaneous OLIF and PPS. One surgeon is inserting PPS at right 5L pedicle. Other surgeon is using navigated curve. Finally, a navigated cage is inserted simultaneously. This reduces OR time. These are the post-op. OR time is just 1.5 hours. Every screw and cage is inserted correctly. If you use simple position technique, you can reduce OR time by 30 minutes because no need to change the position. If you use this simultaneous technique, you can save more than 1 hour. Let's move on adult spinal deformity. We have a lot of this kind of patients. If you use lateral approach and ponteostomy, you can correct this deformity. However, this is a big surgery for elderly patients. I'm a big fan of Professor Anand's concept. We modified his idea to CM-free technique. As he recommends, first OLIF, then the second surgery should be chosen. It can be open or PPS. If curve angle less than 30 or PI minus LL 25 degree, we choose PPS only. All procedures are performed without CM. After draping, use navigated instrument including shaver, curve, curette. Then finally, the navigated cage is inserted. Recently, L5S1 OLIF cage is also inserted in the same lateral position. They have a fantastic retractor, no C-arm. This cage is a hyperorthotic cage. And ALL should be cut, so it's a kind of anterior column release technique. 1 week later, posterior surgery. More than 50% of total cases are candidate for this circumferential MIS. Now we are putting PPS. Post-op X-rays. Deformity is nicely corrected. If vertebrae are fused, it's a contraindication for MIS. Usually, we need posterior open osteotomy for this patient. In this case, CT shows L12 vertebra and facet joints are fused. We perform navigated lateral osteotomy for this patient. These are post-op images. CT scan. Lateral osteotomy was done, and we could get a good correction. Take-home message. Navigated expandable cage is excellent. Simultaneous ORIF and PPS can reduce the surgical time. ORIF 5-1 can create more lordosis than TRIF 5-1 because of ACR. Thank you for your attention.
Thank you, Masato. I have one question which Aravind also has raised. In the cervical spine, the mobility is quite a lot. And
Yes.
even in the pictures that you showed, you could see there was so much of movement, intersegmental movement. How are you so confident to put in the next pedicle screw through a minimally invasive approach? That's one of the things that frightens me all the time.
Yes. Thank you for your good question. For upper cervical, we definitely choose C2 spinal process. It's a reference frame. And for lower cervical, we definitely choose C7 spinal process. And if the case is like spinal cord injury, you should put reference frame into the exactly the same vertebra of spinal process. So, but usually for degenerative disease, you don't have to so much afraid of the navigation accuracy. We will publish the case series. Now we have more than 10 cases to perform this kind of technique. Thank you for your question.
I would like to ask.
David, you have something to tell about it?
I would like to.
In your opinion, there was so much of movement of the vertebra.
Yes.
Yes,
Yeah.
sir.
So in our group in the cervical spine, one of the things that we do, you're absolutely right, Raja, that there's a lot of motion. So we check landmarks with a probe, and then one of the key items is no pressure on the tool. So we will use a drill and no downward force on it to minimize that distortion. And then if we have any question, we will place K-wires in the tracks and sometimes do a check spin to make sure that they're where we want. Obviously, what we're worried about is mostly a vertebral artery injury, and that you will know without a K-wire. But that no downward pressure is absolutely key to not distort your navigation technology.
I'd like to tell you something important. Nowadays, even in the United States, cervical pedicle screw is allowed by your FDA, right? This lateral approach, posterior approach is very safe because the screw angulation is quite different from normal angulation. So if you have a courage to perform our technique, please do it.
Yeah. No, we do a lot of cervical pedicle screws navigated all the time, but it's just a minimally invasive technique. It worries me because there is so much of movement. So thank you, David. Thank you, Tanaka, for this great talks. This was a very good beginning, And now we go on to the debate. Sailesh?
Yeah. So this today's debate is between the navigation and robotic for spine deformity surgery, and we have two eminent speakers from US. Professor Neil Anand will be talking for the navigation and robotics, and Professor Munish Gupta will be talking against navigation and robotics and his experience. So let's see. Over to you, Professor Neil Anand.
Thank you. I hope you can see my screen and can you hear me? Anyway, greetings from the US. Good evening here and good morning to you, I guess. So my task is talk about robotic assist with navigation for adult spinal deformity. So I'm going to sort of quantify that. And these are my disclosures, none of them relevant here. But this is the guy I'm debating, who arguably is probably the best freehand pedicle screw surgeon that I know and I've seen. I've seen him operate a lot. He's a great surgeon, great guy. But I got 10 minutes now to convince him that robotics with navigation is something maybe even he might consider soon, if not in the future. So we're not talking of this. This is old robotics. The Renaissance spine assist that had a track that moved up and down, and robotics was done that way. And yes, this was the way we got to where we are today. But we really need to talk about where we are today. It's a freehand robotic computer-assisted machine that just basically attaches to the side of the operating room table. It's not in your way. You operate exactly the same way, and everything is done out of the pre-operative CT scan. So hopefully I'm going to show you how novel that has become. And this is with navigation. So they both are incorporated into one module now. We have robotics with navigation. And that's what we're going to talk about. So this has gone out of the room. Just imagine that's not there. And that's what we're dealing with, a simple robot just attached to the table. Even Munish, I know today when he leaves Chicago or St. Louis, is not looking at a roadmap anymore. I know even he's not, if not, his kids are going to kill him. He's basically looking at GPS. He uses GPS to get there. And we've gone even beyond that. Today, our cars just drive by ourselves. We reached a point today, we got self-driving cars. The technology is there. We can get to where we want to. We can navigate to where we want to. So yes, technology is here and is here to stay, and it is coming, right? It's out there. And so what data do we have, though? Just like we have very little data on self-driving cars being the best, you're going to see data as infancy in robotics. But there is data. This is Ramezi Lieberman, who probably is one of the pioneers of robotic instrumentation. This is his first 960 screws, 98.9% accuracy. So it's really good and pretty good compared to most other standards. This one is the one I'm talking about, robotics with navigation in the pediatric spine, 98.7% accuracy. So now you got the best of all worlds. We heard everything about navigation from Dave Pauly and Professor Tanaka, and now you add robotics to it, and you're now into a different dimension, and you take the best the world has to offer and put it all together, and we're starting to see that. Now, this case, Munish doesn't need it. He closes his eyes and he can put pedicle screws freehand, and I agree, he doesn't need a robot for this. I won't even ask him to do it. This guy can put a screw literally closing his eye. Even this case, he doesn't need it. He can put screws in. You'll have no problem getting it lined up, getting it perfectly done. And I'll even give him this case. He has no problem doing this freehand or whatever method he chooses to put his screws in and correct it. Though some of us may like some assist here. Not Munish, he's really good. But what about this one? 50-year-old female, wheelchair, T10 paraplegic. 30 years ago at a T10 to L2 fusion. 5 years getting worse and worse, cannot sit. She is actually a Hollywood music video dancer, believe it or not, on her wheelchair. And she's done a lot of really famous videos, by the way. And she's high functioning, getting worse, cannot even sit anymore, and got into a point where you look carefully, she actually developed a sarco joint right below her fusion. She's got a 2-3 literal sarco joint, and you can see that both on MRI and her CT scan. Massive fusion mass on the top, as you would expect. Significantly decompensated, pelvic tilted around, cannot sit. So obviously we're going to take care of her, right? And of course we can do what we normally do. But here's where I thought this made a huge difference. Here's a bone density minus 2.9. We put her on parathyroid hormone analog to get her going. And as Professor Tanaka talked about, this has been a protocol for years where we do the laterals minimally invasively first, followed by screws. In her particular case, we did it all the same day just to get it all done with. So she got all the laterals, as you can see here, and then we did a A-lift in the lateral position, as you can see there, and that's all done. Now we go to the posterior. The key here was we were able to plan every single screw around the screws present before, and the hooks and the fusion mass. And that's what the robot does for you. This is a preoperative CT scan. So it's all planned. Forget the rods. You're going to see why that rod is not a good idea. But the screws, you can plan how to do it. You can plan the screws, the length, the dimensions. So now everybody knows what screw you're using. The robot has it all in the computer. And basically, you're able to plan this without opening anything up. And I'll show that in a minute. These are the time sequences I'm going to go through. At 1:39, the robot is scanning the surface. It does a scan surface. 1:41, we are navigating and assuring the navigation for the robot. 1:46, we're actually taking x-rays where you do a CT to fluoro registration. You take two views, AP and an oblique. That's it. This is then registered with the preoperative CT scan. And I want to walk you through this. Remember, this patient had a lateral now. This is a preoperative CT scan. It is still able to register segmentally bone to bone. The interbody did not make a difference. We were able to register CT to fluoro, looking at each segment individually. This is a game changer. So I don't need a spin in the OR anymore. I'm all going pre-op. So I got it. It's done. CT OR is registered. And we have gone on now. The first screw is in literally 20 minutes. Within 15 minutes, all my screws and rods are in. Within an hour and a half, the whole case is over. That's the incision. Only the skin open. Nothing was stripped. Completely percutaneous. 2 hours skin to skin. We were done with this case. That's a post-op x-ray. Didn't touch the fusion mass. Didn't touch the previous screws. Everything carried out top to bottom in terms of doing it with the robotic assist. Here's a pre-op and post-ops. As you can see, and we got pretty good alignment there. And I think you'll see here is interesting that we were actually able to reduce her lordosis. She's a sitter. Remember, she doesn't walk. She sits. We didn't want to give her the hyperlordosis. Actually made it really well for her. And as far as I know, she's done really well now. She's 6 months out. And I think the key, this was the game changer for me. So much so, here's another one. 66-year-old flight attendant. Increasing back pain 3 years. Prior scoli, T2 to L2. Solid fusion, T2 to L2. Here we go again. We got all this degeneration lower down, massive fusion mass on top, screws, hooks to deal with, instruments to put in. Again, the robot was phenomenal in getting us around this hardware. We didn't have to take anything out, plan it out, put your screws in, line them up as you need to, get the perfect screws you need. The robot gets you to where you want to do it. You guide it down. And I say the learning curve is extremely little as opposed to navigation. I've never done a lot of navigation. The learning curve is really low with this, so whatever be it, it becomes very easy. My fellows are putting it first case and putting it in, and I can see them do it. The feedback from navigation, I know they got it right. I can see that years or post-op. Not completely MIS. We never opened anything, did not touch our previous hardware. Here she is. And you can see that, guess what? Even Munish has to agree because this is from his website, the same case. He had to take out the entire hardware, open T2 to his pelvis, put a beautiful hardware in, like I said, in his sleep, he can put screws. Great construct, but I'm sure he didn't get this done in 2 hours. And I'm sure if he had a robot right now with navigation, he would have loved it for this case. And now I would take all that hardware out. So this is where I think the role of robots with stealth navigation comes in. But not everybody can get in a tight space. It's hard. You know, it's some people just can't do it. You can try as much as you can. You can't. On the other side, you have to keep your eyes on what you're doing. If you're going to keep your eyes away from where you are, it's going to be a complete disaster. So you need to know where you are, what you're doing, and how you're going to use these tools to make it work for you for the right patient. Otherwise, you can expect a disaster all the time. So I'll go back to the old thing. A fool is a fool who doesn't know how to use his tool right, but he'll never make a bad surgeon good. But even Manish, the greatest surgeon he is, I think can become awesome. And that'll be his patient dancing away. Next day, poached up. Even Manish can go with robotics and make this happen. So it's intuitive and only a matter of time, I think. Driving cars are going to be here. Similarly, navigated spinal robotics. I think it's a platform for many great things to come. And I think we just got to judiciously use it. And I hope I'm convinced, Manish. Thank you.
Thank you, Anand. That was really great. Very convincing. We know you will make a very good pitch. But let's see what Munish has got to say. Munish?
So I got to stop sharing, right? You good? You good.
Yes, please stop sharing. Yeah.
Good evening, everybody. Good morning to you. I'm going to give you the case for the freehand technique. You have some great people giving you all the advice on how to use navigation and robotics. So the issues to discuss are general applicability, radiation, efficiency, accuracy, and cost. Can it be applied to every deformity? How much radiation are we exposing ourselves or our patients to? Is it efficient in terms of time in the operating room? And then how accurate is it and how different is it from other maneuvers such as robotics and CT navigation? And how expensive is it? So if you look at, there are three ways. One is freehand placement, and you can confirm with fluoroscopy or x-rays. Then you can use fluoroscopy to assist you in putting the pedicle screws. And then finally, there's placement of the screws with CT navigation. Well, if you look at the radiation exposure, as we've started using more and more x-rays, there's a 25-fold increase in prevalence of thyroid cancer amongst spine surgeons. This was reported at the SRS by Ted Wagner. And then if you look at the dose for the surgeon, it's minimal, 0.096 for fluoroscopically assisted placement in the AIS. But if you multiply by a lot of cases that you might do, it adds up. And you should have only maybe 50 millisieverts of radiation per year. The radiation to the patient is also increased. If you do a CT-based image guidance, it's like more than 7.29. And if you do that multiple times, let's say you change a screw or confirm a screw, so it's about 40 to 85-fold more than just fluoroscopy. And the breach rates were marginally decreased. It was more accurate. So their conclusions were basically that freehand pedicle screws has very low radiation exposure to the patient and the surgeon. And the freehand placement should be reserved by surgeons that are well versed in this technique. That means you should be good at it. And then finally, in cases of very abnormal anatomy, you might want to use fluoroscope or a CT navigation, whichever you know how to use. Well, you might say, well, I live in Kerala and I get 12 millisieverts anyway. Well, you don't want to add to that. So this is from just your environment, you can get radiation. There are some other studies that show that there's no benefit to the pedicle screw accuracy with navigation versus freehand technique in scoliosis. And what they found was their accuracy rate was pretty similar in terms of grading the screws on violation. And then the upper thoracic spine was the worst area for violation for navigated and freehand screws. But the only grade 3 violations were from the freehand screws. So navigation is more accurate. So the CT-based navigation was only slightly justified with mild or moderate scoliosis. And the research is needed to confirm the usefulness in complex spine, which I agree with. So the caveats are, I do not do many MIS cases except microdiscectomies. I do not use robots, and I've used navigation rarely. I use freehand techniques in most of my cases in thoracic, lumbar, and iliac screws. And then I've used fluoroscopy for placing pedicle screws when the landmarks are obliterated. So the tools needed are rongeur, high-speed burr, pedicle probe, a ball tip probe, and a power screwdriver. Simple stuff. And the preoperative planning is absolutely essential in my book. Plain radiographs, MRIs, if available, CT scans on very severe curves. And 3D models have added one more layer of pre-op planning for me. Study the pedicles pre-op. Use intraoperative radiographs or C-arm as needed. And if it does not look good or feel good, just leave the screw out. This is the technique I just want to show. By placing the points of fixation, a burr is used to decorticate the transverse process and make the entry point. The pedicle probe is then used to cannulate the pedicle, and then a ball tip probe is used to make sure that there's no violation of the pedicle walls. Bone wax can be used to stop the bleeding from the pedicle hole before insertion of the pedicle screws. Pedicle screws are then placed. Sometimes, in order to identify the landmarks, the facet joints have to be partially removed, and the pedicle entry point can be found, and a burr can be used to define the entry point, and the pedicle probe can then be used to find the pedicle screw tract, and the appropriate size and length of pedicle screws are then placed. So typically AIS case like this with a thoracic and lumbar curve, you can see that it's pretty rigid and rotated in the lumbar spine, not very flexible. This is the clinical photo of thoracic hump, lumbar hump. And then this is the x-ray, we measure everything. And then we look at the MRI scan if it's available to see where the cord lies and what the pedicles look like. And we measure them pre-op. As you can see, this is a pretty cortical pedicle here. And this is the lumbar spine. And we make a map before we go to the operating room of what the pedicle sizes could be. So this is the exposure. We always check the level, and then we do the releases and put the screws in. And if you're having trouble putting a screw in, you can feel through the releases, the pedicle, and then put the screw in. And we get an x-ray with the screws, and we also do EMG testing for the screws. And then we put the rods in to correct the spine, and then finally the picture with the correction. And you can see the correction. And this is only 5 x-rays, no fluoro, no navigation. Some ridiculous cases, big curves, same thing, do a CT scan on big curves, and then you can look at where the narrow pedicles are, and then you can plan if it's going to be outside the pedicle in or through the pedicle, and then we have this all available to us before we do the case. So this is the x-ray after, and you can see the correction of the cage, and a pretty good result from a severe curve. Some really bizarre scenarios where you have very severe kyphosis. You do a CT scan, but I think a 3D model is even more beneficial in these cases, and everybody has 3D model capability now. So this really helps plan and execute the surgery. You can see the result here. Even worse, big curves, put in halo traction, and then did the fusion. And we did that. We did the CT scan and 3D model before we did the vertebral column resection on that patient. Let's say you're doing this curve, and some of the pedicles are small and you can't get them. So don't forget the sublaminar wires. You can use sublaminar wires in these cases. And it gives you a pretty good result, as you can see here. You can see the cosmetic deformity as well. When to use navigation in my book, if you have a case like this where you have a fused spine, broken rod, really falling off the top, the CT scan is helpful, but for me, the 3D model is quite helpful. We can actually make the rods in different colors so they're distinguished from the bones. And you can plan out your vertebral column resection. You can mark the vertebrae you want to take out ahead of time. So we used a 2-stage approach where we put the screws in under navigation where the fused spine was, and there were no landmarks to follow. And then that was the first stage. And then we came back and did the vertebral column resection at the second stage, and you can see the result there. So why use freehand technique? It requires little equipment. It's very inexpensive compared to navigation and robots. It can be taught easily to residents and fellows. All our fellows are pretty good at it by the time they leave our fellowship. There's no extra radiation exposure to you or the patient, and there's no extra time needed to set up the navigation and robots. That seems to be the longest time sometimes. And it can be applied to majority of the open cases. And, you know, if you don't have a lot of money in a hospital, you might want to spend it on patients rather than equipment. Thank you so much.
Thank you, Munish. Always impressed with the cases that you show. But unfortunately, God created only few, I think only one Munish around the world. I was going to say few, but it's fantastic. Neil, do you have to say a 1-minute rebuttal, and then I'll come back to Munish?
You know, it's hard to argue with Munish's talent, and I will not even go there. But I think not everybody can be Munish, and I think when it comes to a difficult case, I will give offhand that for a normal, regular case, you probably do not need a robot or navigation for any regular spinal deformity surgery. But I think it's the difficult cases that make the difference, and it's a huge help. And now with robotics, with the navigation, I think it's truly a game changer today, as opposed to just navigation or just the robot as it was before. That combination today, to me, is huge for 2 reasons. One, no intra-op CT, so less radiation. You're using the same pre-op CT that I would have got anyway to do all the planning. And the radiation dose to the patient and you is now down. It's actually one step further. And to me, I think it's a platform for much greater things to come. So it's pretty exciting where we are.
Okay. So Neil, just one question. Have you had mishaps with this? Because there is a lot of question. No doubt robot is good for ordinary cases, but there is a lot of apprehension amongst surgeons that robot can have a major mishap in cases with gross deformities. So do you have a full-fledged study, a prospective trial on robot on gross deformities?
Full disclosure, I've only done 15 cases with the robot and navigation put together. The navigation thing was great because now you could see. I was actually pretty reluctant to do robots by itself in major deformity, but you have no idea where the robot's taking you MIS. So I actually would not do it. I only did that open where I could see the landmark. So I sort of gauge, okay, the robot's taking me the right place, right? Now with navigation, I'm comfortable doing MIS. But I got that added feedback. But you're right, is there going to be a mishap? So at some point there is. Luckily, they haven't added. I really think the robot with the navigation has changed it. You can on the fly change your orientation on the computer to redirect your screw today. So let's say you did have a bad screw and you felt it's wrong. You can actually take it out right there and then, adjust on the computer, have the robot shoot it again. And we did have that twice. Twice we had to reorient the screw. So the technology has evolved immensely today. So I think we're talking of robot. To me, I'm talking of robots with the navigation, the latest one we have today, as opposed to, I think you guys have Renaissance, and I'm not sure Mazor X and other have come, but they're getting there. I think it's there.
Okay. To Munish, one question. Munish, at any point of time, even in the worst cases, do you ever have felt, oh, I wish I had a robot or a navigation to help me?
Well,
many pedicle screws, misdirected screws, and you lost the screws. And have you ever thought, if only I had navigation?
Well, first of all, I want to thank you guys for putting this together, and it's really nice to see your faces. I've missed you guys a lot. That's number one. Number two, I think we pretty much agree with everything we're saying. We have the same common theme, and I will answer your question in a minute. I just don't want people to become spine surgeons and not know freehand technique and go to the operating room and say, if you don't have computer navigation robot, I can't do the case. That's number one. I think you have to learn that. Number two, navigation, robotics, all these things are fantastic because they're going to add to our armamentarium. And with technology advancing, they'll get cheaper, so it's not much of a burden. If you're in a small town in India and you can't afford it, you don't feel like a third-class citizen. And the last thing I would like to say is that, yes, of course, there are cases where you think you might need it, but I have found that when I do the releases and I can feel the pedicle from the inside, it's pretty safe. And I'm not afraid to put a sublaminar wire where I can't put a screw. You don't have to have a screw in every pedicle.
Thank you, Munish. I would like to thank Sailesh. I don't want to leave the first session late. And it's been really great having the best of the faculty across the world. Sailesh said there are two surgeons from US, but I would like to point out that Munish and Neil are from India, not two surgeons from the US. So David, Masato, Munish, and Neil, it's a great pleasure to have you. You're great friends of India and ASSI, and it was a wonderful way to start. So thank you, Gautam. Thank you, Ankur. Thank you, Sailesh. And we leave. Bye-bye.
Thank you, everyone. It was a great session. Thank you all. Thank you.
I thank the moderators and the faculty. We move on to the next session, and we have the moderators already here. I welcome Dr. Raghav Dutt and Dr. Rupinder Chahal for the next session, which is going to be on complication in spine surgery. Over to you, Dr. Chahal.
Rupinder, you are muted.
Dr. Chahal, you have to unmute yourself.
Yeah, good morning. I welcome all you to the next case-based panel discussion. That's the complication in spine surgery. And my co-moderator, our senior ex-president, Dr. Raghav, is with us. And the panelists will be Dr. Bharat Dave, Dr. Vijay Kumar, Dr. Prashant Kekre, and Dr. VSP Rao. Can we invite the first case, that is dysphagia following anterior cervical surgery by Charanjit?
Good morning, everybody. Welcome.
Good morning.
I welcome you all to this case-based discussion. And I, being the first batsman, would be facing the most difficult deliveries. Coming straight on my case, the case that I'm going to discuss today is that of a 68-year-old lady who has been having cervical spondylotic myelopathy for a long time. I'm sorry, my screens are not moving.
Just click on the screen and then see.
Yeah, so it is a 68-year-old female who has been having neck pain and upper dorsal pain for 2 months duration. The pain was non-mechanical in character, worse at night, and for the last 1 month, the pain was so severe that she was unable to sit, stand, or log roll in the bed without any pain. She was a known case of cervical spondylotic myelopathy due to an OPLL, Nurix grade 3, and was being managed conservatively by local orthopedicians. And that was so because she was recently diagnosed to have a CA esophagus lower third a year ago, which was deemed inoperable and was managed with chemo and radiotherapy. So she was not willing for any sort of treatment for her myelopathy. Since she was having unrelenting upper dorsal pain, we decided to have an MRI done, thinking that she might be having metastasis. But when we did the MRI, we found that she had a infective spondylodiscitis at D1, D2 level with the epidural abscess irritating the dural sac. So these are the MRI pictures at the time of presentation. We decided to have a CT guided biopsy done with an intervention radiologist. but he refused to do a biopsy in view of past history of CA esophagus and radiotherapy. So the ball was again in our court, and it was imperative on us to get a sample for diagnosis. We did consider a transpedicular biopsy, but we thought it was difficult because of the overlapping shadows of the shoulder blade and the proximal humerus. So we decided to do an anterior open biopsy and a debridement as well as a reconstruction at the same time. It was an extended Smith-Robinson's approach. The tissues were edematous and hypovascular under the influence of previous radiotherapy. We got the plane between the trachea and the esophagus medially and the carotid vessels laterally. And the infective tissue was harvested for gram stain, culture, as well as histopath. But no sooner than we had harvested the sample, the patient had unexplained bradycardia and hypotension. And this was followed by asystole. The anesthetist advised us to abandon the procedure and close the wound. The wound was covered with an ioban. Immediate resuscitation was started. Patient was revived and stabilized, and then the anesthetist gave us just enough time to close the wound primarily. Patient was shifted to ICU on an endotracheal tube and ventilator. Cardiology review was obtained. Patient was stabilized over the next 2 days and was extubated on day 2. It was indeed a very rare organism, Streptococcus pseudoporcinius, and there are only few reports of it causing discitis in patients. Liquids were started on day 3, and to our nightmare, the patient had dysphagia. Even to liquids, she was not able to swallow liquids and was regurgitating every time she attempted to swallow. So I would like to stop at this stage and would I like to ask Dr. Rupinder, how would he be managing such a case in his scenario? Dr. Rupinder.
I would have actually considered a transpedicular biopsy in this case. Because if your main aim was to make a diagnosis, I think, and since we do a lot of this kyphoplasty, vertebroplasty, we use the same instruments, and it's easier to difficult, but you still do it in an AP view. I would do that.
I would have in hindsight also done the same, but since this lady was having a very short neck and we did have an X-ray and we saw her under C-arm to see whether we are able to reach there, it was virtually not possible to see the vertebra in the lateral view. Even the AP was a little bit difficult because she was osteoporotic. May I ask Dr. Prashant how he would be proceeding with this case?
You hear me?
Yes, sir, Dr. Prashant.
Yeah. Well, the first thing is when you approach this in view of the past history of CA esophagus, and did she have any radio chemo, if I mistake not?
Yes, sir, she had a chemo as well as a radiotherapy.
There was no surgical intervention there. So
no surgical intervention, she was inoperable.
So that would have been my first thought, that whichever area I'm going in, even if it's in the lower part of the cervical spine or cervical thoracic junction, I probably would have done a barium study to find out if there is an esophageal abnormality first. But I know I'm going to handle the esophagus even if it's not for the purpose of corpectomy or interbody fusion. So after doing the barium swallow, probably I would have got an idea whether certain part of the esophagus, especially the posterior one, whether it has thinned out. Because whatever little retraction you did on the table to get a biopsy, or even probably with the view of at least putting a probably that could have helped me. That is step number 1. On the table, again, if that is the thought in my mind pre-op, on the table again, I would have probably tried a barium swallow to see whether anything is out. Because this is a high-risk esophageal retraction. So these are the 2 things I would have done pre and intra. Post-operatively, now you know it's a leak, Charanjit. Isn't it a leak, a proper leak?
Not a leak as of yet, sir. It's a dysphagia right now.
It's a dysphagia now. So again now, if I were to do pre-op swallow, intra-op swallow, I know whether it was a leak or not. Even now, probably you could do a barium swallow to find out whether it's a leak or not. Because if it's a leak, the biggest risk that you face is of mediastinitis.
Okay, let's ask Bharat Dave. Bharat, you're the cervical guy. What do you think? Should we do now? No, let's forget the past. Now we have a problem. The patient is not able to swallow. What should we do? That is the question.
Yeah, I think as pointed out correctly, we would like to know what's the reason for the dysphagia. Right. And I know this case very well, and I have my comments at the end, so spare me for this discussion. I think you can carry on with that because my last 5 minutes are related to the same only.
Okay. Anybody else volunteer to do? What should be done now? Right now, what should we do? Patient is not able to swallow.
stent the esophagus, if I may answer. I talk about the past, I talk about the present now.
Sorry?
May I?
Yep.
Yeah.
Yeah, I think we should certainly do some kind of a radio-opaque swallow test to find out where the dysphagia is. Because while it is kind of simple to assume that the dysphagia has been contributed to by the anterior cervical approach, there is a good possibility that the CA esophagus is the culprit here. So we need to find out whether the dysphagia is happening at the level of the pharynx esophagus or it is further down. Yeah? So I think that would be the first study. And so some kind of a radio-opaque swallow test with or without an endoscopy to see where, if at all, the restriction in the movement is. Okay?
Yeah. Would you do a CT or just barium swallow with a radiograph?
See, more than a CT, nowadays I think, they don't use barium because barium is very thick. So
Yeah.
I think they use kind of omnipaque kind of thing because also they're more liquid and less viscid and more likely to give you a clearer picture.
Okay.
So I think I would first do that and then maybe an endoscopy to get one of the gastro guys to assess what's happening with the esophagus. And also the third thing, as you're saying, whether the dysphagia is truly a dysphagia or the start of a leak. And that is another thing which would actually be seen early on by an endoscopy. One can have a look inside to find out whether there's any breach in the wall of the esophagus.
What if
I
there's
think
a
these are
leak?
the
What do we do now? Suppose there's a leak.
I
What
think
should be the
then,
next step?
yeah, see, the biggest worry is mediastinitis. Now, from what it sounds like this lady is really not fit for any further surgical procedure, because she's already had an episode of asystole with the last anesthesia. So I think if she does develop a leak, then the plan would be to put a drain locally to kind of drain it out, and then maybe put in a feeding,
Yes.
a peg tube to allow her to, feed without a lot of transit through the esophagus.
Let's get back to Mandeep. Is that what you have done, Mandeep?
Yes.
Sir, I think Dr. Bharat Dave will explain it, or
Yeah.
we still have the case now. Yeah.
So that is what we did. We did a oral contrast with a CT, and it did show a posterior leak. You can see the dye extravasating into the wound and was almost reaching to the skin. So we got in our multidisciplinary approach. Now we had a patient who had a esophageal tear, a discitis at D1, D2 with wound infection, in a past history of esophagus with radiotherapy. So as discussed in the panel, we asked the GI surgeons to have a look. Primary repair was ruled out because the esophagus was very thin and there were only tags seen. Augmentation with a muscle patch was being planned, but because the local tissues were avascular, the sternocleidomastoid was fibrotic. It was not possible to do that. Fibrin glues and esophageal stents were also discussed, but were ruled out because of the past history of radiotherapy and CA esophagus. So we decided to manage it conservatively. We passed in a Ryle's tube under direct vision when we were debriding the wound for the second time across the gap and also across the esophageal tumor under vision. The patient was kept on NPO for 6 weeks. Parenteral therapy, nutrition was started, and 2 weeks later, a feeding gastrostomy was done. She was, of course, treated with an IV antibiotics, broad spectrum, but more importantly, we also started WAC dressings twice a week for the next 4 weeks. And at the end of 4 weeks, the secondary healing was obtained, and this was with a formation of esophageal cutaneous fistula. She was able to swallow liquids by blocking the cutaneous opening of the fistula. At the end of 6 months, the discitis had healed. She was restarted on chemotherapy for the esophageal cancer. And with respect to her myelopathy, she was ambulatory with support. But she spent agonizing 2 months in the hospital, had to undergo multiple WAC dressings, a feeding gastrostomy, and she spent a fortune while her stay in the hospital. And not to forget the anxiety and the uncertainty she had during her stay in the hospital. So this was one of the worst cases that we have managed in the recent time, and it has taught me to be a lot less aggressive, especially in patients with severe comorbid conditions. Thank you. And now I would like to unshare my screen so that Dr. Bharat would give his commentary on the case.
Can I share my screen, please?
I have unshared my screen, sir.
Yeah, sure. Can you all see my screen?
Yes, sir.
Yes, sir. Go ahead, Bharat.
Sure. Good morning. Yeah. So the case commentary would be probably, this is not a criticism, but I would have done it completely differently. As we discussed earlier, would have done the biopsy, and I would like to share my view. It's a challenging case, and it's like, who is going to bell the cat? And that was something, Dr. Charanjit did. And at the end, he won, but with the lot of anxiety and a lot of stress. So probably PET CT was done, and probably I would have staged the disease and survival of the patient as well. And maybe probably on day one, we could have done the gastrostomy, feeding gastrostomy too, because the esophagus had CA, which was inoperable in the lower part as well. So that was something which may be one of those things, multidisciplinary approach will help us in planning the surgery and the overall treatment plan. Biopsy, probably I would have considered, and probably that would be my first choice, because biopsy will certainly tell us, and probably patient may not need surgery because patient had myelopathy neuro grade 3 earlier because of the OPLL. So, giving biopsy, and as discussed earlier in this talk as well, that, the transpedicular biopsy, which we can do very well, and I'm sure it can be done in AP view. You do not need lateral view for the same as well. Yes, because of the short neck as mentioned by Dr. Charanjit, but yes, I would certainly go for the transpedicular biopsy. And we have good Jamshedi needles as well. So that would be my choice, posterior transpedicular biopsy. I would certainly have approached this from the back because of the technology which we have, because we have become more bolder now with the pedicular screws, and even C7 pedicle screw can be put in as well. So certainly something like this could have been handled better from the back. And certainly, we can sacrifice the nerve root between T1 and T2, and one can do the LICA as well if required. As mentioned, biopsy and probably the osteoporotic bone, that certainly would pedicle screw would have given the better approach and better grip as well. Now, regarding going back to the anterior approach, just look at the transmandibular, the upper part of the sternum, which is just touching at the D1, D2. And I'm sure it is very difficult to get into T1, T2 without doing the manubrium, rather sternal, the splitting or whatever way, but the access would be certainly limited because the T1, T2 and the short neck. So it is just at the manubrium. So this is how probably I would also differ from the anterior approach too, because it's going to be very difficult. So difficult to access, proper cutting, maybe manubriotomy. I would just like to share a couple of cases where we had the same sort of situation. 75-year male, ankylosing, treated from front surgery, and we did that, and you can see the MRI, and patient recovered very well following the surgery. Same way, this patient who had commando surgery, infection in the disc space, treated conservatively, and did very well through the transpedicular biopsy approach as well. So my take home would be for this patient particularly, I would have gone from the back, C7, T1, T2 fixation with the decompression if required, because this patient had no neurological deficit related to the current pathology. After fistula has developed, as we discussed in our discussion my talk, I think probably we would like to know from where the leak has, and then accordingly this was treated and managed. Certainly RT, if it is possible to put it through that tumor, then probably maybe, but feeding jejunostomy or feeding gastrostomy has been done. Primary repair probably usually in such case may not be possible. Even we have had few the tear, and in one patient we managed to repair it. In other two, we managed to treat them conservatively. So this is something that has been our experience as well. So thank you very much for let me share my view.
Thank you, Dr. Dave. Thank you, Dr. Charanjit. And after a rare case of Charanjit, we come to a very common problem that we encounter most of the time. That's the CSF leak following lumbar decompression. Now I invite Dr. Appaji to share his case.
Sorry. Good morning, everyone. Morning, Chahal and Raghav sir. This is a patient which I would like to share. A patient came to me with a dural leak, operated somewhere else. This was a good learning experience because this was a patient which we had to open 3 times. So I don't have intraoperative pictures because most of them were like, we were more worried about this patient and we couldn't take pictures. So without much ado, this was a 59-year-old female with a neurogenic claudication in both the lower limbs. Underwent surgery elsewhere 5 days back. They've done a L4. It was a spondylolisthesis which was already fused. So, but they had done a L4 L5 decompression with stabilization. She had come to me on the 5th day. She was discharged on 2nd or 3rd day from there. 5th day with wound soakage. The soakage was not associated with fever or pain. The local examination showed a dressing which was soaked with pinkish fluid. Skin clips on the wound. On removing the dressing, clear fluid was leaking from the lower end of the wound. Edges were clean. There was no induration or tenderness and no warmth in the local region. This was the index pictures. I have these pictures of the patient. She was a fused L4, L5 spondy. Even in the MRI, it's a fused case. So they had done a wide decompression and inserted screws. This was the post-operative picture which I had when the patient presented. So the patient had come on the 5th day. So I will let the panel discuss this case now. Dr. Vijay Kumar can take over, or Dr. Raghav can ask questions.
Okay. Hi. So I think this is the kind of scenario that all of us face at some point or the other, either in our own patients or patients who come from elsewhere. And again, if we sort of look at the situation at that point in time, particularly if it's not your own case, then it is always a difficult sort of management algorithm on what to do. And I think I will sort of later on in the case commentary go through a little bit of the literature, but I can tell you right in advance that the literature is not very clear on what are the best ways to proceed. There is no standard of care on how you actually manage a CSF leak. So my thoughts would be that, you have a relatively clean wound with a leak from one end of it. Yeah. And my initial instinct would be to say, why don't we just suture that and then put in a lumbar drain, because that's a relatively sort of very non-invasive thing to do. And that may often, win you the situation. So what would be the views of Raghav? What would you think?
Yeah, what I would do is what I learned in my life. All of us have faced this difficulty so many times. What I would do in initial stage is take a 3-0 or 4-0 nylon or ethylene or proline and do meticulous wound closure. That means it is so watertight that the problem with CSF is it will go into spaces where there is the CSF has a chance to leak out or come out. So I would do that first, and it is so meticulous that I will not allow anybody else to do it. I would do it, or my senior team member would do it. And that will solve the problem a number of times for most of my patients. So it should be atraumatic. Yeah. That's the first step.
Yeah. Can I intervene, sir?
Yeah.
Yeah. Can I intervene? If this CSF leak, the next slide was that. So what happened? It's not moving again. Yeah.
Yeah.
So if it was not an identifiable leak, it was not identified. Like you said, if there was a leak which was identified during surgery, yes. But if it was not an identifiable leak, what will you be doing, sir?
So now, Appaji, the problem is there is a leak now from the skin of the CSF, right?
That's right.
Yes, sir. Yes,
So
sir.
we have three options here. I mean, two options, basically, to either put a catheter above to drain it out, a lumbar drain, or we have to re-explore. These are the two options left for us, apart from resting and keeping it in the lateral position. These are all pretty standard things that we all do. So what I would do, initial stage, is do with an atraumatic needle. It should be 3-0 or 4-0. Do the suture, and majority of times it should be so watertight that it will solve the problem. Not necessary all the times, but majority of the times. That's what I would do.
Appaji, I think if the leak is discovered in later on, during your primary surgery, you don't see it, I would definitely re-explore and see where the leak is. If it's at an identifiable level, I will definitely suture, as Dr. Raghav said, and do a Valsalva and see if there is no more leak and still cover it with the Durafoam. But if it is not, it's in the shoulder or some places where you can't do it, I would still then know that I would use a Duraform or something, and I need to protect this patient for a long time, put a lumbar drain, keep him on bed. So all those things. But to identify where it is, it's important, I think.
Yes, Dr. Bharat, yeah.
I would like to keep two drains. One drain deep there where, it will keep on sucking, which I will keep it positive. And the second drain superficial to that. After the muscle layer we have stitched. And the deep drain comes out early once it stops draining few ml only. And we can keep the patient, and that is how we manage at our center. Or else even we let the track come as well. And then we have taken the purse string suture, and then we just tie that. So that is how we manage it.
Yeah. So this patient had come from outside. So my instinct was to re-explore. So I re-explored the wound. The patient had leak at the shoulder of the root, and shoulder and slightly anterior, not amenable to repair. And it was a low pressure leak. I could see CSF coming, but it was not like pouring, because maybe the CSF had dried out. And there was an increase in CSF flow on valsalva maneuver. So I did manage it with a fat fascia graft and tissile, wound closing layers, as everybody said. I kept a drain for this wound also, and kept the patient on bed rest. The wound was dry for 4 days. And then I thought, okay, I'll mobilize the patient before removing the drain. I mobilized the patient, and there was soakage on the 5th day again. So next point, Dr. Vijay.
Yeah, I think that is the more difficult situation where you go from a problem to begin with, and then the problem doesn't resolve with your intervention. And in our country, one of the biggest issues is that the cost for the patient is mounting, and the relatives are getting very restive. So you see, I think again, to be honest, it is all belts and braces. So I think if you have already had a look and seen that it is over the shoulder and not amenable to a primary repair, then one of the things again to try and do is to put in a lumbar drain as well, because you can sort of reduce the sort of outcoming pressure. Often the problem with these small tears is that they are like a valve, and the CSF can come out but can't go back in. And small tears are more prone to give you CSF leaks than actually large openings in the dura. Yeah? So that was a traditional sort of neurosurgical teaching. So that is I think a lumbar drain would be something that would allow you to, but it needs to be done at the same time. The problem when you start getting into a sequential situation is once the CSF fistula cutaneous starts getting established, then your wound does not heal. The CSF stops the normal healing of the skin and subcutaneous tissues, and that becomes a bigger problem, with time.
Dr. Prashant, what will you do now, sir?
Well, the patient has come. Can you hear me?
Yes.
Yes, sir. Yes, sir.
Yeah, patient has come on the 5th day. So exploration is necessary for two things. One is whether the defect is suturable. That is one. Most of the times the tissue is very friable. At least I have not found it easy. What I mean by me is my neurosurgical colleague has found it very difficult to suture that. Whatever the length, I'm not talking about a small leak. Number two is exploration secondly important because to know where the leak is. If it is a posterior leak, the positioning of the patient post-surgery becomes extremely important. That is, if it is posterior leak, I would keep the patient prone. Anyway, patient is going to be very uncomfortable, whatever you are doing. So prone with head low, in addition to a lumbar drain. If it was a leak, as you said, in the shoulder, small and not amenable to suture, I would do the same thing, like use tissile, and depending upon which side the shoulder is, that is right or left, opposite side, lateral position with head low. In addition, of course, lumbar drain.
Yeah.
Paji, can you go ahead?
Thank you, sir. So I took this patient to the cath lab, placed the lumbar drain now. The wound seemed clean for 3 days, and I mobilized the patient with the lumbar drain, but there was soakage again. The patient attenders had become impatient, wanted a permanent solution. So I took again now help from the neurosurgeon, as Prashant sir said. So we did a third intervention, a re-exploration. We made a opening in the dura just above the leak. inserted a fat graft from that opening into that, plug that opening in the shoulder. We applied a blood patch. I do not know. This was something which I learned from that neurosurgery experience. They said even epidurally, you can just leave a blood, let it clot before closing, and then let the patient. There was no drain which was kept on the wound, but we left a lumbar drain which was removed after 96 hours. Patient was managed with rest for a week. Wound healed well, and then we mobilized her. She's now 1 year. She's doing fine without any fistula.
Don't do an MRI on this patient.
Comments from Dr. Vijay Kumar. Yeah.
Yeah. Can we have case commentary by Dr. Vijay now about this case? How he would have done it?
Sure. Can I have a screen share, please?
Appaji, yeah.
Yes,
Could you share my screen, please? Yeah. Okay, so I think this is a sort of fairly common problem that we all face as spine surgeons. And unfortunately, if we look at dural tears and CSF leaks, then the reality is, despite all due care, it happens. If we look at the kind of frequency with which it happens, then obviously it varies with the complexity of the surgery. So for a single level decompression or a microdiscectomy, the rates are below 2 to 4%. But as we go into increasingly complex situations of revision surgeries or redos or multi-level fixations, complex deformities, then the rates can be as high as 30%. Now, again, when we looked at it prospectively, then during a 5-year period, Jeff Wang reported an incidence of about 14%. And their assessment was that most of us tend to underestimate our rate of CSF leak, because unless we get into a situation like Dr. Appaji, which is very memorable, the smaller leaks which healed up uneventfully, we are likely to forget. Again, this was a study by Tafsel in the European Spine Journal, and they looked at the whole of the north of the United Kingdom and 14 institutions there. And their rate, again, as predicted, was 3.5% for primary, 8.5% for stenosis surgery, and higher for revisions at 13%. And as they also commented on the same thing, that there is a wide variation in the actual and estimated rates of CSF leaks among spine surgeons. In my fellowship in Louisiana, we looked at the factors which influence the occurrence of CSF leak. And the two things that were found to correlate was age of the patient. So the older patients were more likely to have a CSF leak, and the level of the surgeon's training. So the younger surgeons, the trainees, were more likely to get a CSF leak. And the other thing that we found was the kerosene ronger was the instrument that was most often the culprit. And it is when you undercut the bone and you can't see the tip of the ronger, that is where you're most likely to also take a bite of the dura. And that is why I think, the shoulder of the nerve root is again one of those areas where you're kind of looking, over the nerve root and you're trying to protect the nerve root and you don't see the tip of the kerosene.
Dr. Vijay, can you tell us what you would do for this case, not this theory? Okay. We all know this.
Yeah. Okay. So, look, if you can see an incidental neurotomy and, then we would sort of repair it at that point in time. But in this particular case, where it wasn't detected at the time of surgery, then, as I said, the first thing that, I would have done when this patient came would have been to meticulously suture the wound and put in a lumbar drain. That, in the vast majority of studies, say by Stossen and Hughes, then this was found to have actually allowed the wound to heal up. If the wound heals up, then usually you do not have an issue. So the most important thing is to try and get the wound to heal up. So like Dr. Raghav said, the first thing that I would have done is meticulously suture the wound, put in a lumbar drain, and hopefully that would have got me over. Now, if we come to the next situation, like Dr. Appaji, where I did this, waited for 3-4 days, it looked fine, and say day 5, again, it started leaking, then definitely I would do what Dr. Appaji did, which is to explore the wound, have a look inside there. And if I find that it is a suturable leak, then to suture it. If I find that it is in a situation where it is not possible to suture this, then exactly what Dr. Appaji did, in the sense that we would put in a fat or a fascial graft. There are lots of dural substitutes. Duraform is the thing that we use. So you can pack down Duraform widely over the dura, put in some Tissile, definitely, put in a lumbar drain also, because this patient has had decompression and fixation. So there is a lot of dead space there. And one of the problems of CSF leak is that wherever there's a dead space under low pressure, then more likely for CSF leak to persist. So at the time of the exploration, I would definitely have also put in a lumbar drain at the same time. Yeah? And in the situation where, despite that, if we get a leak again, then truly, I agree with Dr. Appaji, you really do not have an option other than to re-explore and try and sort of open up the dural area, put in a fat and partial graft. So I think he was just unlucky that his first re-exploration did not actually sort out the thing.
If I may interrupt and ask you, is this technique of putting a fat graft intradural, which I have seen with some of our neurosurgical colleagues, is that a good technique to do? Or do you practice that?
We do practice that, particularly if you have small, tiny little tears, because what happens with a small puncture or a tear is that there is a tear in the dura and the arachnoid is torn at a different place. So that is what creates like a slit valve. Now, when you put in a little piece of fat then you actually go through the dura, through the arachnoid, and you're into the subarachnoid space. So that fat then, really bolsters not having this kind of like a slit valve between the arachnoid and the dura mater. And that is often the culprit. Now, the other thing that I was saying before, that the smaller holes and punctures are more likely to create this kind of a valve situation. And our old traditional neurosurgery training was that if you find a small tear that you can't repair, then just make it bigger and leave it alone. Big tears, see, we do, all of us do spinal intradural tumors. And you open the dura widely, and it almost never creates a problem, isn't it? It is only the small tears that create a problem because of this slit valve mechanism.
Thank you,
Sir. I think we have to stop now.
We have to stop now and get on to the next speaker. Thanks very much. That's a good point for all of us to put a small fat graft in these small leaks and get on with good closure. Thank you very much.
So we can continue the discussion on the chat. We move on to the next case, that is the pseudoarthrosis following the lumbar TLEF. I invite Dr. Ankur to share his screen.
Thank you, Dr. Rupinder. So I hope my screen is visible to all. So I'm going to be presenting on this case, a pseudoarthrosis following lumbar TLEF. This was a 59-year-old gentleman. He was a government officer who came to me with complaints of low back pain for the last 2 years. The pain was radiating to both thighs and calves. There were paresthesia, tingling numbness in the both lower limb. His claudication distance symptoms had been there for almost a year, right more than left, and walking distance had progressively reduced to around 100 meters in the last, I think, 2 months or so. He also gave a history of smoking for the last almost 30 years, even though he was not somebody who was smoking a huge amount of cigarettes a day. But yes, he did have a long history. Neurologically, he was normal. He was able to walk on the toes, walk on the heels. He was bladder continent. I decided to investigate him, thinking of a lumbar canal stenosis, and this is how his MRI looked like. And you can see that there was severe stenosis at the lumbar fourth and lumbar fifth vertebra with the sacralization of L5. The facets looked pretty bad. There was some amount of facet fluid, a lot of facet hypertrophy getting into the lateral recess. You can see the osteophytes jutting into the traversing roots at L5. and to my mind, he needed to be, given the benefit of a surgery. So we went ahead and we did a standard 1-level TLIF for him. We did a interbody cage, and the patient was so grateful post surgery. All his pain and everything was hugely better, and it was a very happy story. The patient came down to us at 3 months of follow-up, because he was from, usually we get a lot of people from other parts of the country. So this patient was from, I think, Bihar. He came for a 3-month follow-up. At 3 months post-op, he complained of some back pain which was happening, and we investigated him. We did an X-ray. The X-ray looked okay, and since he was complaining of back pain, I also did some infection markers to rule out if any infection, late onset infection is there, which came out to be normal. Unfortunately, I do not have X-ray from that period at 3 months. But at that point of time, everything looked good. He was walking around, 2 to 3 kilometers. Only thing was he was having back pain. So we've called him for follow-up as usual. We call them at 6 months. And this is what he came up at 6 months. And you can see that there seems to be a cage back out, which has started happening. At this point of time, he was still having back pain. He was quite mobile, and he had started developing numbness on the left side on walking. So his walking distance had reduced a bit as compared to the 3-month follow-up. So this is where we are as of now. So I would ask the panelists, maybe start with Dr. Vijay. Sir, any comments on this?
Yeah, hi. Okay, slightly sort of difficult situation where you have a, not very old person with reasonably good quality looking bone, and then, he's getting backage of the cage. I think given the fact that he's now got some claudican symptoms, it would be useful to get an MRI at this stage to find out how much the cage has backed out and whether it is actually causing any significant stenosis. So I think that would be the first thing to do. As you said, you've already done the infection markers, and there doesn't appear to be any obvious lucency around the screw. So I'm not sure that there is any loosening or back out so far. Looks similar to your first post-operative X-ray. So I think maybe at this stage, just get an MRI to find out what's happening with the canal.
Dr. Dave, sir, same thoughts or anything different?
No, I would share the reality with the patient, put the hard LS belt, advise the patient to restrict the mobility and activity, observe in the next few weeks what is happening. If it is staying there, I'm sure this will heal and it will improve his mobility in the coming days. But I would, as you said, infection markers are negative, so my approach would be a little more conservative.
Okay.
There is a very important point here.
Yes, sir.
Why the cage has backed out here? That is, I think, the important question we have to address to. There has to be some problem with the locking mechanism of the rod and the screw. That could be the only reason why cage has to walk out. Otherwise, if the cage has to walk out, there has to be some mobility. I don't think we should classify this as a non-union, because there is no implant breakage as such, or there's nothing that which failed to unite. Basically the cage has backed out.
The left L5 screw seems loose. Yeah.
That is the problem here. There is a problem with the implantation. It is not a non-union.
No, it's 6 months. We can't still call it non-union. Would anybody do a CT instead of an MR, or would somebody do both?
So we generally do a CT scan in these patients. We had few of them, and CT would give us an idea about the cage position and erosion of end plate or early infection if it's going on.
Right.
And we have set upon it like this, that what Dr. Dave said it, but end of the day, they don't stay there. They actually come out. So we have tried pushing back the cage also, it didn't work. So now what we do is we take out this cage and just pack it with lot of tricortical iliac crest graft. So once the cage has come out, it makes a position. It is you cannot reposition it. It's a high chance that it always comes out. So always what we have learned is we now never reuse this case or push it back. put a lot of bone graft and they're all doing well.
What about your implant, Rupinder? Do you change the implant?
Yeah, we look at all the screws also, sir. If the screws are loose, we put a higher screw, diameter screw, or if it is the pedicle is still not holding well, we take another level.
Surya Prakash, what do you think you should do now? What would you do? You have tried conservative.
For
Would you ever
me,
try conservative, Surya
for me,
Prakash?
somehow, see, this cage has backed out into the canal and it is going to do that further. Wishful thinking by putting him on corset and all are not going to work. You have to get in and take the cage out first thing and put a tricortical graft. Where I am suspecting here that the locking mechanism of the screw and the rod, whatever nut is there is some problem there. Otherwise, there is some subtle mobility why the cage has walked out. Otherwise, why should a cage walk out?
But why do you think
sir, if I can
Surya Prakash, to answer your question,
excuse me,
Surya Prakash, to answer your question, the reason it is very well known that plastic cages or PEEK cages walk out more than titanium cages, and this is because there is a chronic inflammatory reaction sometimes which occurs around the cage, and therefore they walk out. It is not necessarily because of mobility and of the rod and screw junction. And it's not necessarily because of infection always. It happens because of this. I have had a few patients myself. And what happens is, since we put graft anterior to the cage, that fuses and the cage then remains in place. If the patient is asymptomatic or minimally symptomatic, as soon as it fuses, it settles down and really it does not cause problems in the long run. So I would agree with Dr. Dave that it does not necessarily require a surgical intervention immediately.
Sir, if I may interject here, so
one second.
We have the case left actually. If I can just make a comment on what Dr. Rao was saying. So this is just to say it's an imported implant. We always give pre-tensioning to our cages, and if you see the L4 and L5 is actually in a little bit of lordosis. So the cage was compressed and there's no loosening at the rod and screw construct. Anyway, the patient was offered a surgical intervention at this point of time, and surgery was discussed. But because he was walking more than a kilometer or so, the patient was not so much convinced at this point of time, and he decided to not go ahead at this point of time. So we also offered him to watch. Now this is 1 year follow-up. He's back from Bihar, and this is what we are looking at. We have now a cage which has further backed out, and we have now an obvious looking implant loosening. And I think this is where I wanted to let the discussion go further. We investigated it at him at this point of time, and this is what his MRI looks like.
Yeah. Go back to the X-ray, please. Go back to the X-ray. Yeah.
Yeah.
Is there a loosening of the L5 screw on the right side?
Yes, sir. I have marked it, sir. The screws are loosened up there.
Yeah. Okay. And no evidence of infection on blood markers now.
No infection of evidence of infection, sir. This is what the MRI is looking like. Blood markers are normal, sir. And now his walking distance has come down significantly.
Okay, let's stop there. Let not everybody talk. Surya Prakash, what do you think we should do now?
No, I personally feel we should remove the cage.
All right.
Because it is causing compression and it is causing symptoms of stenosis.
All right. And what about the screws? Would you go for a bigger diameter screw?
Maybe we just change the screws to a bigger diameter screw, or maybe use a cement or something like that to hold the, really, if you cannot put a good screw, you probably have to fix it in a very stable manner.
Would you put a cage again?
No, not required now. Basically, the bone which has been placed in the front would have healed to some extent.
Right.
And, I think really, see, all the time placing cages is only the recent phenomena. Earlier, many times we were putting tricortical grafts and we had decent outcomes.
Yeah. Okay, let's move on. Rupinder?
Ankur has completed your case.
Yeah, so the case is complete, and I'll just left with showing what we have done. Any comments from the panelists on the shape of the cage which you use, biconvex cages or flat cages?
No. Ankur, we don't have time. Please, can you move?
Okay, we can move on. So what we did is this is the last slide. So we did a revision. We took out the cage. We also removed the left L5 screw because it had cored out quite a lot. And this is the patient's now 5-year follow-up. What we have started seeing is there is a solid fusion with the tricortical graft there. What you see is something happening on the above section where there was very minimal osteophytosis before. Although patient is asymptomatic, is doing well, but this is something I don't know whether we're going to have an adjacent problem soon, or is it going to fuse?
No, I don't think he will have an adjacent problem. He has a tendency to throw bones.
Yeah. So just one comment from my side. Actually, these are the cage which I used here. It was a very flat cage. I have used a very few of them, and I've seen that these flat cages have a more tendency to back out than the ones which are biconvex. So I feel biconvex cases are better.
Dr. Chal, we are 5 minutes late.
Over to Dr. Prashant for his commentary.
Sir, Dr. Prashant, sir, 2 slides for what you would have done.
Can you share my screen, please? Can you see my screen? Hello?
Not yet, sir.
Okay, anyway, I'll go verbal if there are time is a constraint. Well, yes, two things here. One is in his history, he has very clearly said that it was a case, the person was a smoker for a long time. And therefore, I would take this very seriously. Although there is no quantification of how much smoking, how many years, and how it can affect. But smoking and pseudoarthrosis is more commonly connected than on all other factors which may lead to pseudoarthrosis like osteoporosis and what have you. Number 2, and therefore in the first instance when I did the surgery, there have been many papers which have said that, if there's a definite history of long-term smoking, it is better to either cancel, postpone, or at least modify the surgery. In this particular case, anybody here feels that there was an option of only decompression and not a fusion? I would have done the same what Ankur has done, because it was a case where there was going to be a requirement of a wide decompression. So all said and done, having done a TLIF at L4, L5, can you hear me?
Yes, we can hear you, sir.
Yeah. Having done that, I would have more closely followed up the patient. Like when the patient came at the end of 3rd month, I would have definitely done a CT to find out, because TLIF, a well-done TLIF is a procedure where the patient is absolutely comfortable and really happy at the end of 3 months. So when he came back, I would have probably done a CT and not an MRI. I'm not looking at the smoking part at all. I would have done exactly the same thing, but that would have given me an indication as to the loosening of the screws at that point of time, and accordingly I could have gone further. However, this didn't happen for various logistical reasons. Patient comes at 6 months. At this point of time, the cage having slipped out, whatever be the cause, he has got the early neurological symptoms. I would not be treating or looking at a non-operative option. It has never worked in my hands. Patient only worsens, and the worst part here is the cage will burrow into the dura and cause dural tears at the time of extraction. So I would advise the patient it is better to get it done. I would do extraction of the cage, and the more important part comes now. Somebody said that, like Ankur did a higher level. Yes, higher level is necessary, but at that level, probably I would also put autogenous graft. Higher level, of course, you put a screw, extend the instrumentation, and put again an autogenous graft. Because the important thing here, if there is no infection, one can very conveniently conclude that this is pseudoarthrosis secondary to the smoking. And therefore, we need a material in the interbody area which is inductive and not like PEEK, or for that matter, calcium phosphates. So therefore, I would use autologous graft at the time of cage removal, as well as the higher TLIF which I am going to do.
Thanks, Prashant.
Yeah.
Prashant, I think that was a nice advice to all the youngsters and to seniors as well. I think we will move on to the next case. It's a problem that we all face, most of these problems that we have discussed today. Chahal, kindly take over, please, Rupinder.
Yes, sir. We move on to the last case, that is intraoperative loss of neuromotoric signals during scoliosis correction. Dr. Vishwash, please.
Yeah, try to share my screen. Can you unshare the last speaker?
No, we were seeing.
It's already unshared. You just need to share.
Is my screen visible?
Not yet.
Starting to screen. Yeah.
Yeah.
Okay, good morning. Good morning, sir. Good morning, Raghav, sir, all panelists and moderators. So I'll be presenting a case of intraoperative loss of neuromonitoring signals during scoliosis correction. So this was a 16-year-old male who came to us with deformity noticed by the parents recently. Patient comes from non-consanguineous marriage, the parents with a normal birth history. There was no NICU admission. Patient cried immediately after birth. Milestones and immunizations were normal. This is how the patient looked like, with the head central, hairline normal. Right shoulder was at a slightly higher level. Right scapula was more prominent. Patient presented to us with a dorsal kyphoscoliosis with convexity to the right side. The left arm trunk distance was increased as compared to the right at the lumbar level. The pelvis was symmetrical. There was no LLD. On forward flexion, the right dorsal paraspinal region becomes more prominent. There was no neurodeficit as such at presentation. Abdominal reflexes were symmetrical and plantars were flexor. So as per our normal protocol, we do the loaded versus unloaded x-rays, the whole spine, supine and standing films. The supine film showing a Cobb angle of around 62 degree with a kyphotic angle of around 68 degree. The standing films increasing the Cobb angle to 71 with a much more increase in kyphotic angle of around 78 degree. So we also did the bending films, the supine bending films, right and left, did not show much change in the Cobb angle. So it was quite a rigid scoliosis, rigid congenital kyphoscoliosis. These are the CT scans, which shows that there were two hemivertebrae. One was on the right side at D6 and one was on the left side at D9. So there were two hemis, as you can see clearly in the CT scan, the 3D reconstruction, throwing two curves on the upper part and the lower part where the hemis were located. There was no bar or any other anomalies of the vertebral body. MRI did not show any major intraspinal anomaly, but there was a central seedings, which you can see extensive seedings from D2 to D8. Otherwise, there was no major neuroaxial anomalies. As per normal protocol of any congenital scoliosis, we did a screening ultrasound of KUB and the whole abdomen to rule out congenital urogenital anomalies. None was there. We did a 2D echo also, and this patient was found to have a dextrocardia. So how do we approach the patient? Raghav, sir?
Amitav, what we will do is we'll get on with what you have done, because it's a very important topic.
Okay.
All right. You have done surgery, isn't it? The problem is loss of the signals during surgery, right? Let's get on to that.
Right, sir.
Yeah.
Sir, we were planned for hemi excisions, multiple level facetectomies, hemi excisions, and a posterior standard instrumented deformity correction under neural monitoring. This was our plan.
Right.
So we did an exposure under neural monitoring. We used TIVA and under standard exposure, and started doing the facetectomies. We did all the facetectomies from D4 to D11, and also we used the freehand technique to put in the screws from D4 to D11. But after putting in the screws, even before we captured the rod, the MEPs were maintained at around 80 mean arterial pressure. So after putting in the screws, there was a drop in MEP on the right quadriceps and the right ankle dorsiflexor, right tibialis anterior. So even before putting the rod. So here you can see the baseline MEP, which was okay. And here you can see that there was a drop in the MEP of quadriceps and more of the tibialis anterior. This was an initial drop. The neurophysician actually alerted us. We waited, and then the signals started dropping more and more. And ultimately, we almost had flat line in the right quadriceps and the right tibialis anterior. More than 80% amplitude drop of the MEP.
Yeah,
okay.
Amrita, here we'll just take a small break. Hello. Yeah, small break. Can you go back to the earlier slide? Well, no, before this. can you go back to the before this, where you exactly said what you did? Yeah, please. See, yeah. Next. Here, what exactly happened is that, no, don't go to this. Get to the
you want a
surgical
CT,
part.
sir? CT.
Surgical part. What you have put, what you have done.
Okay.
What you have done. See, what I understand from what was done here is he just exposed, did a basic facetectomy, and placed the screws, and then you found the neural monitoring not good. Basically, that is what I understood.
Yes,
the question here is
putting the rod.
How often you keep doing the neuro monitoring? Do you do it after every screw, or do you screw after a bunch of screws?
So we do after a bunch of screws, especially on the concavity. While we are doing instrumentation, every time we don't take MEPs. So especially if we are contemplating on the concavity screws, we ask them to take the MEPs.
No, because here it is the right side which has got the problem, right? That is the convexity, if I understand well.
Right, sir. Right.
But here in this case, you have put convex screws, and these convex screws have caused the problem.
Might be. We were not sure.
Because see, how I understand the neuromonitoring works is, generally placement of an implant within the bone of the spinal column should not cause any problem unless your screw violates and hits the dura or the nerve. As long as you don't do that, usually placing the implant will not cause any problem. It is the manipulation of the spinal column which causes the problem. See, here you have not done any manipulation of the spinal column. You have just placed screws, and after the placement of screws, when you checked up the neuromonitoring, it was not good. So how I am trying to understand is...
Surya Prakash, 1 second.
But we have done
facetectomy. Are you saying that by putting a screw, right, which breaches, sometimes it can happen either on the concave or convex side, would that not lead to a loss of signal?
That is precisely what I'm saying. It is not the manipulation.
Okay. We have
let him complete. We'll come to Dr. Surya Prakash's commentary later on. I think let Vishwas complete the case.
What did you do, Vishwas?
But we had actually done the releases. We have done multiple fascectomies before putting in the screws. So we checked
Now let's conclude now, because we have, time is a big problem for us.
Right, sir.
Now you have lost the signal. What have you done?
So we checked the mean arterial pressure and raised the mean arterial pressure from 90 to 100. Core body temperature was checked. The temperature of operation theater was raised. All leads were checked. And then what we did is we removed the right-sided screw. The signals were not coming up actually. So we waited for almost half an hour, 40 minutes. And then we actually removed the right-sided screws. And then further waited for 30 minutes.
Was there a breach after removal of the right-sided screw? Was there a breach of any screw?
No, there was no breach, sir. There was no breach. And we checked under CM also, and after removal also, there was no breach.
Okay, next question. Have you done? Do you do a Stagnara at this time?
We have not done Stagnara at that time. We waited for the MEP signals to come. We waited for 30 minutes after removal of the screws. And then we found that the MEP started slightly improving. It almost came 10% of the baseline, like that. There was a slight improvement in the MEP. Slowly, the MEP started improving, but not more than 10 to 20% of the baseline.
Can we move to commentary, please?
Yeah, commentary.
Yeah.
See, as I understand here, it is not exactly the manipulation of the spinal column which has caused the deficit in this case. Most of the times, whenever we do a case of a spinal deformity correction, the placement of implants usually, whenever he said that we check it after a bunch of screws. In my personal practice, every 3 to 4 screws I keep checking, because I am also worried. Sometimes inadvertently I might sort of breach the pedicle and hit the dura and cause iatrogenic deficit because of just implantation per se. So I think maybe it is more prudent to do more frequently, because the machine is always there. Keep checking each and every time whenever there is an issue, or whenever you place a screw, you can keep checking, because it doesn't cost anything. Everything is there and the patient is readily available. So had that was done, probably we would have known exactly at which point this problem has happened. Maybe he could have avoided screws altogether at that zone. Right. Ultimately, he has accepted a in situ sort of a fixation.
Right.
Which I think this is a very, very high risk case to begin with. See, the problem here is the patient has got a syringomyelic cord, and syringomyelic cord doesn't tolerate manipulation as well as a normal spinal cord. Suppose if the same thing was done in idiopathic scoliosis, it would have been a jiffy. I mean, there would never have been any problem whatsoever.
Okay, Surya Prakash, there is no breach here, right? There is no manipulation here. Now, how do you explain the 90 mean arterial? One second. Mean arterial pressure 90 is pretty good for a young person. There's nothing wrong with it.
Yes.
I'm sure the temperatures were okay. So what was the problem here?
That is precisely I'm not able to answer because
facetal release did little bit manipulation of the cord or something.
No, because see, facetal release, you are not moving anything. No, you are just excising the facet.
All right.
Maybe as you did the facetal release by putting number 1 or number 2 upcutter into the recess as you cut the inferior superior facet, you could have inadvertently caused some iatrogenic damage.
I think, Surya Prakash, I think we have to stop. We are getting signals. I think that could have been a good reason that the problem has occurred. I agree with you. And thank you all panelists, my co-moderator Rupinder, and lovely discussions of some of the common problems that we encounter in our lives as spine surgeons. Thank the organizers and thank you all. Catch up in the next sessions.
Thank you all.
Thank you. Thank you.
Thank you, sir.
Thank you, the moderators. It was a very interactive session. We move on to the free paper session, and I invite the moderators, Dr. Raghavendra, Dr. Tarun Suri. Is Dr. Tarun Suri here? Okay.
Yeah, Tarun is here.
Okay, and then Karunakaran. You may start the session. Thank you.
Good morning, everyone. Are all the free paper presenters ready and present? Are the papers loaded up?
The papers are loaded up. The presenters are here. Only Dr. Bharat HD, who's speaking at 10:10. He's not going to be speaking, so we can speak that speaker. Okay.
Okay. Dr. Tarun Suri, is he here?
Yes, he's here.
Okay. Okay. Hello.
Raghavendra, you can just call up the names. They will put up the videos.
Yeah.
Yeah. Yeah, I'll do that.
Can Shailesh Sushil, can you start putting the slides of the first speaker?
Can you please? Yeah.
Dr. Sanjeev Asati.
Yeah, the first.
Morning, everyone. My topic of presentation is comparison of applied anatomy at L4-5 and L5-S1 in context of tubular decompression for lumbar canal stenosis. Lumbar canal stenosis is the most common indication of spinal surgery in elderly, with L4-5 level is the most commonest level involved. Laminectomy and decompression is the treatment of choice. Tubular decompression is popular and prevalent technique of minimally invasive decompression for LCS. The morphometry of L4 vertebrae and L4-5 facet articulation is different from L5 vertebrae and L5-S1 facet articulation. And no study till now has described the technical differences faced during L5-S1 tubular decompression as compared to L4-5 level. So the aim of current study is to delineate the technical challenges of tubular decompression at L5-S1 level as compared to L4-5 level. 48 randomly selected patients were chosen of age more than 45 years from OPD who underwent MRI for back-related issues. Patients with spinal trauma, tumor infection, deformity were excluded. After application of exclusion criteria, 40 patients were included in the study. The radiological parameters were evaluated at L4-5 level and L5-S1 level. The different parameters which was measured manually in axial MRI cuts for interlaminar angle, which was measured between the lines that are in the plane of right and left laminae of vertebra. Tube angle, which was measured between a vertical line drawn along the spinous process and a line drawn along the lamina, which was collinear with the tube. Ratio of thickness of the lamina, which is the thinnest portion of the lamina at L4 and L5, and the laminar length ratio at L4 and L5. The hypothesis behind the study was that if this patient have to undergo tubular decompression in future, then what will be the difference between doing the surgery at L4-5 level and L5-S1 level? The mean age of the patient in the study was 56.8 years with male is to female ratio of 3:2. The parameters that were evaluated were interlaminar angle at L4-5 was 71 degree compared to 102 degree at L5-S1 level, and the tube angle at L4-5 level was 36.8 degree as compared to 49.7 degree at L5-S1 level. The difference between interlaminar angle and tube angle between the two groups was statistically significant. The laminar thickness ratio at L4-5 was 1.34:1, and the laminar length ratio at L4:L5 was 1:1.42. So for global decompression, it depends upon the ability to incline the operating table, tubular retractor, and the microscope. The factors that determine the degree of inclination are the depth of the contralateral recess and the angle made by the contralateral lamina with the vertical line. So we can safely assume that more acute the angle, the lesser the inclination. So the current study analyzes these factors in an objective way to put forth an argument that tubular decompression at L5-S1 are led with some unique complexities. Interlaminar angle is significantly higher at L5-S1 in compared to L4-5, which makes the working angle steeper and demands a higher degree of tilt. And tube angle was also much at L5-S1 level, meaning that a great effort has to be made by operating surgeon to obtain a more convenient access to the contralateral recess. Widening of the interpedicular distance as we go down from L4-5 to L5-S1, which was objectively noted by measuring the laminar length from the midline to lateral recess, which was higher at L5, almost close to 1.5 times. This assumes importance since it makes the access to contralateral decompression deeper and farther. Thickness of the lamina important in context of execution of decompression of contralateral side. A thick lamina will provide sufficient latitude to perform an internal decompression using the drill and ronger without fracturing it. And a thin lamina has the potential to break while drilling and decompression, leading to inadvertent entry into soft tissue, which can lead to disorientation of the anatomy and bleeding, which is difficult to control. The limitation of the study was that non-stenotic MRI images were considered and evaluated. However, the authors comprehend that this will not influence the revelations and the impact of study. So the take-home message from the study is that tubular decompression at L5-S1 level has its own challenges. Wide interlaminar angle of L5 as compared to L4 dictates more oblique tube docking and more extensive table tilting. Thinner lamina at L5 has the potential to break while drilling and disorient the anatomy. And a longer distance of lateral recess from midline at L5-S1 makes the access to decompression deeper and farther. So the author recommends the surgeons to be cautious of these facts while performing tubular decompression at L5-S1 level. Thank you.
Thank you, Dr. Sanjeev. The next paper is going to be, we will have the discussion after the first 5 speakers. So we will move on to the next paper, which is about prophylactic C5 foraminotomy as a mode of prevention of C5 post-op palsy in a laminectomy of cervical spine. The speaker is going to be Dr. Vikshet Basani.
Good morning. Can prophylactic C5 foraminotomy prevent post-operative C5 palsy after laminectomy in cervical spine? C5 palsy, that is new onset deltoid paralysis, is a well-recognized complication known to occur after posterior decompression surgery. The incidence that has been reported in literature is always been very varied. Yet the etiology still remains elusive. So the purpose of this study was to evaluate the role of prophylactic C5 foraminotomy as a preventive measure. So we conducted a retrospective study at a tertiary care spine center where patients over a 3-year time span with cervical stenosis and myelopathy who underwent laminectomy plus or minus foraminotomy and completed a minimum follow-up duration of 1 year were included. We excluded patients who had undergone laminectomy for causes other than degenerative myelopathy. Radiograph analysis was done and parameters calculated on X-rays were C2, C7 corpse angle, C7, T1 slope, and presence of instability at C4, C5. So the types of signal changes that were analyzed on MRI were type 1, where there was diffuse and faint hyperintensity, Type 2, where there was focal and sharp hyperintensity. Type 3, where both type 1 and type 2 hyperintensity characteristics were present, and 2 discontinuous focal hyperintensities were present. Now, the CT parameters analyzed were intervertebral width of C5 foramen bilaterally and anterior protrusion of C5 superior articular process were analyzed on CT scan. The images were acquired in horizontal plane of the intervertebral disc. Now, the post-op analysis was done using the radiological parameters like C5, C2, C7 corpse angle, and post-operative cord shift. The posterior shift of spinal cord at the level of C4, C5 was measured from the posterior edge of the compressive mass to the midpoint of the spinal cord in the mid-sagittal plane. So the pre-operative values were then subtracted from the post-operative values for the measurement of spinal cord shift. All radiological parameters were independently assessed by 2 spine surgeons and the mean value was considered. So when coming to the results, a total of 126 patients underwent cervical laminectomy in this 3-year study duration, whose mean age was 62 years, and of them 87% were male. And of all the procedures, 73% underwent laminectomy as compared to 27% undergoing laminectomy plus foraminotomy. Diabetes was the commonest comorbidity. So these were the radiological parameters. So the mean C2, C7 corpse angle was 14 degrees and C7, T1 slope was 22 degrees. So the maximally compressed level was C5, C6. So the post-operative parameters, a total of 23 patients developed palsy post-surgery. 14 patients were post-laminectomy and 9 patients were post-laminectomy plus foraminotomy. There was no statistical significant difference between these two groups. Maximum patient developed palsy in the second operative day. Mean C2, C7 corpse angle changed to 20 degrees from 14 degrees. The average posterior cord shift post-operatively was 3 mm. So based on univariant analysis and multivariant analysis, we could come to a conclusion that prophylactic foraminotomy can be considered in patients when these parameters were met, like there was reduced cervical lordosis, presence of instability, focal change on T2 weighted MRI, protruding C5 superior articular process tip, and reduced width of C5 foramen. Thank you.
Thank you, Dr. Vikshit. The next paper is going to be on cervical facet joint effusion as a sign of instability in cervical degenerative spondylolisthesis by Dr. Srikanth Sagani.
Good morning. My topic for today is cervical facet joint effusion, a sign of instability in cervical degenerative spondylolisthesis. So to begin with, cervical degenerative spondylolisthesis has not received as much attention as its lumbar counterpart owing to its lower incidence. Dynamic radiograph are generally utilized to diagnose spinal instability. Identification of the features of instability on the MRI is crucial to avoiding the missing the presence of cervical degenerative spondylosis. Facet joint effusion has gained significant importance as a telltale sign. Facet joint asymmetry and hypertrophy have been suggested as a feature of cervical instability. However, cervical facet joint effusion has not been highlighted and discussed as an important sign of cervical degenerative spondylosis. The aim of our study was to trace the association between cervical facet joint effusion and cervical degenerative spondylosis. It was a retrospective radiographic review of cervical spine MRI scan and upright lateral flexion radiograph of 16 consecutive patients from single institution. Patients with signs and symptoms of cervical spondylotic myelopathy with radiographic evidence of cervical degenerative spondylosis were included in our study. Patients with MRI more than 1 year apart, previous spine surgery, any deformity, any inflammatory arthritis, and malignancy were excluded from our study. The facet joint effusion measurement was taken perpendicular to the apparent joint line, and cervical spondylosis, which is measured on upright neutral lateral extension radiograph using Taylor's method, and displacement was graded by using Kawasaki and ETA. Total 16 patients included in our study, 11 male, 5 female. Mean age was around 65.8 years. 10 patients revealed spondylosis at C4, C5, and 6 patients revealed spondylosis at C3, C4 level. This is the demographic data showing the cervical facet joint effusion. The amount of facet joint effusion ranged from 1.7 to 4.7 millimeters. 9 patients demonstrated the facet joint effusion associated with cervical degenerative spondylosis with translation to vertebra more than 3.5 mm, while 7 patients with cervical degenerative spondylosis does not demonstrate any mobility more than 0.5 mm. Cervical degenerative spondylolisthesis mainly involve upper cervical level, that is C3, C4 and C4, C5. This is mainly because of progressive degeneration and stiffening of the lower cervical level with the age. The recognition of the fascial joint diffusion on the MRI should prompt the clinician to rule out any dynamic instability. This is a flexion extension radiograph showing mobile cervical spondylolisthesis, while this is a T2-weighted sagittal MRI image showing reduction of the spondylolisthesis in extension. Dynamic radiograph are generally utilized to diagnose the spinal instability. Commonly, patients presenting to the OPD with MRI films because of wider availability of the MRI, this can be used to execute the treatment plan in the patients. This is a axial image showing the fascial joint diffusion around 4.7 mm, and this is a sagittal image showing the fascial joint diffusion. The effusion was uniformly unilateral in all the patients. This may be just because of the intermediate phases of degeneration on the way to the gradual progression to the bilateral effusion. Effusion does not occupy any potential space, but it is a result of progressive erosion and attrition of the articular surfaces. However, the site of effusion can be used as an excellent host area and can be packed with significant amount of bone graft. This assumes the critical importance from the point of view of stabilization, since the lateral mass fixation is possible on the contralateral site. Caputo et al. Have described the fascial joint asymmetry and hypertrophy on the MRI scan as a feature of CDS. Based on MRI, Caputo et al. And several authors have described the fascial joint diffusion as a sign of instability in lumbar spine. The presence of fascial joint diffusion has been considered to be one of the key factors accounted to decide whether we have to go ahead with the fusion. MRI is generally performed with the neck in extension and the disease get reduced in extension, and the presence of mobile cervical degenerative spondylolisthesis may be masked and hence missed. In a patient who reveals degenerative spondylolisthesis as well as fascial joint diffusion on the MRI, the presence of effusion will prompt the clinician to perform the flexion extension radiograph to check whether the segment is mobile or fixed. This is a small size study. In terms of treatment, larger studies will define if all the patients with CDS and effusion will need the fusion or standalone decompression. So to conclude, the current study acknowledges the association of cervical fascial joint diffusion and cervical degenerative spondylolisthesis. Clinically measurable fascial joint diffusion on the MRI suggests the need for further attempt to diagnose the cervical degenerative spondylolisthesis. Thank you.
Thank you, Dr. Shrikant. Now we move on to the next paper, which is comparison of mini-open modified TLIF with traditional open technique and outcome analysis of 2 years follow-up, a retrospective study by Dr. Vishnu Prasad Panigrahi.
Respected faculty members and delegates, a very good morning. This is a study comparison of mini-open modified TLIF with traditional open TLIF and outcome analysis at 2 years, a retrospective study. So there are many techniques described for TLIF, the traditional open method and the mini-open and the minimally invasive technique. The drawbacks of the open are the extensive superior stripping leading to muscle necrosis, blood loss, significant postoperative pain, delayed recovery, and adjacent segment disease. At the same time, the minimally invasive TLIF with tubular retractors includes steep learning curve, unfamiliar paraspinal approach, radiation exposure, and higher expenditure and longer operative time. In the present study, a single incision mini-open technique was used to minimize the limitation of both the techniques. So the surgical technique include a midline skin incision, followed by creating a subcutaneous pouch, followed by insertion of guide wires through the facial incisions, then a subperiosteal dissection on the symptomatic side, and the facetectomy has been done, and flavum and annulotomy has been done, and the disc space is curated, and the end plates are prepared, followed by insertion of cage and bone graft. Then pedicle screws was inserted in all the pedicles over the guide wires, followed by compression, and the similar step also used on the contralateral side. This is the final skin incision, which is around 5 to 7 centimeters. So the basic objective of the study is to compare the clinical and radiological outcomes. So it is a retrospective including 52 patients, 26 in each group, and high-grade listhesis and dysplastic listhesis were excluded. The clinical data collected were visual analog score, Osworthy disability index, SF36, duration of surgery, intraoperative blood loss, difference in pre and postoperative hemoglobin, number of days of mobilization, and duration of hospital stay and postoperative duration for return to work. X-ray was done at 6 weeks, 1 year, and 2 year follow-up. Preoperative baseline data like age, gender, preoperative VAS, and ODI SF36 were comparative. And at follow-up, Both the groups saw significant improvements in symptoms compared to preoperative, while the mini-open TLIF group showed better symptomatic improvement and early recovery. They also had less blood loss. They also have less drop in hemoglobin, less requirement of blood transfusion. The mean duration surgery was less, and the hospital stay was also less. They were mobilized early and they returned to work early, and they were significant statistically. Similarly, postoperative VAS was back pain was less compared to the open TLIF group at 6 weeks, 6 months, and 12 months, but now there was no difference at 24 months. And the similarly mean ODI and SF36 was significant in the first 12 months. It was better in the mini open TLIF group. There was one complication of CSF leak, one misplaced screw, and one case of pseudoarthrosis, which was not clinically symptomatic. So in conclusion, mini-open TLIF reduced approach-related morbidity as compared to OTLIF in view that it has a relatively small skin incision, less muscle dissection, reduced blood loss and minimal transfusion requirement, minimal postoperative pain, early ambulation, and reduced hospital stay and early return to work. At the same time, it also reducing the cost as compared to the missed TLIF, as there was no requirement of specialized tubular retractors. So mini-open TLIF have a long-term result comparable with the open TLIF with a moderate learning curve and with slightly higher radiation exposure. Thank you.
Thank you, Dr. Vishnu Panigrihi. The last paper before we break for discussion is going to be by Dr. Sagar Sharma, Pitfalls and Complications Associated with the Reduction of Spondylolisthesis.
Good morning, one and all. Today I am presenting a paper on pitfalls and complications associated with reduction of the spondylolisthesis. Instrumented fusion has become the standard treatment for spondylolisthesis with persistent symptoms and progressive sleep. In situ fusion provides satisfactory functional outcome, but reduction and stabilization improves the spinal pelvic balance and correct the deformity. However, reduction is technically challenging. Advantages of reductions are better restoration of the statal balance and possible clinical benefit in terms of functional outcome. Disadvantages are prolonged surgical time, more incidence of complications like increased blood loss, post-op neurological deficit, etc. It is technically challenging and it requires high surgical skills. Method of reduction includes the prone positioning, distraction technique, use of reduction screws and screw puller, complete decompression and soft tissue release followed by reduction. In high-grade listhesis, a vertebrectomy or osteotomy may be required. Objective of the study is to evaluate the complication and functional outcome of the patient with spondylolisthesis who have undergone reduction. It is a retrospective study and patient had undergone surgery for listhesis in past 10 years were included in the study. The data source was a medical record specs and spine registry maintained by the senior author. It includes 75 patients who were diagnosed with spondylolisthesis and underwent a surgical and posterior lumbar interbody fusion. Patients with minimum of 2 years of follow-up were included in the study. Our method for reduction for degenerative listhesis included the prone positioning of the patient, and the most of the patients we achieved reduction by this, follow which instrumentation and decompression was done. In stomach listhesis, positioning did not bring the reduction, so we have done a laminectomy and the removal of the loose posterior fragment. Then anterior disc was removed and screws were put. The cage introducer was put into the disc space and distraction was done, and a vertebral body was levered up. This is the pie chart showing the grade, and this is the table showing the level of spondylolisthesis in our study. Our study includes 43 degenerative and 32 ischemic spondylolisthesis cases. As the table shows, we were able to establish significant in both ODI as well as VAS for ischemic group and only in VAS for degenerative listhesis cases. The mean surgical time and the mean blood loss was 254 minutes and 864 ml but there was no significant difference between the two groups. Slip was reduced completely in 24 patients in degenerative and 11 patients in ischemic group with post-op lumbar lordosis of 30.9 degrees in degenerative and 12.9 in ischemic group. Necessity of reducing loco-regional deformity is main contention point for surgical management. In our study, reduction was achieved in 36 degenerative and 18 ischemic spondylolisthesis patients. This shows the difficulty in reduction in ischemic group. In our study, 5 patients had neurological deficits and 4 were recovered on follow-up. The cage migration was seen in 3 patients for which the cage was removed and the patient did not suffer any neurological deficits. 6 patients had dural tear and which was repaired intraoperatively. This is a picture showing the loosening of the connecting rod with pathological fracture. This is a picture showing the posterior cage migration. Coming to the conclusion, our study shows a higher complication rate in high-grade and stomach type spondylolisthesis, but our results are comparable with the result available in the literature. Thank you.
Does that mean that we've finished all the 5 discussions?
Are there any questions for the free papers?
Yeah, let me ask the first question to Dr. Sanjeev Asati.
Yes.
This is Dr. Karunakaran.
Yeah.
This is regarding, what about these fascial arthropathies? Was there an issue when you were planning for these cases, fascial arthropathy at L4, L5 versus fascial arthropathies at L5S1?
So, sir, this study basically we have included only the patients with the normal MRI images, not the degenerative one. But usually when we do cases at L4-5 and L5S1 in patients with facetal arthropathy, the side of the tube locking is usually decided by that. If one-sided facet is has a more arthropathy, then we usually dock the tube on the opposite side to get a better docking at the levels. But we have not compared the data between L4-5 and L5S1 level in patients with facetal arthropathy.
Good. One more thing is, was the orientation of the facet an issue, like vertically oriented versus more horizontally oriented facet or facet tropism? Was there any issue?
So, sir, in study we have not included that facet orientation. But usually we try and dock the tube on the side which has a more coronal orientation of the facets, because it may lead to a iatrogenic instability if we dock at the sagittal oriented facet and if we cut out the facet more.
Thank you, Dr. Sanjeev.
Thank you, sir.
Okay, so I have a question for Dr. Vishnu. Dr. Vishnu, in your study comparing the mini open TLIF to the open TLIF, did you have any MRI criteria to select the cases for mini open TLIF or any clinical criteria? More specifically, I wanted to ask, was your technique, how did you modify your technique for patients who had bilateral symptoms?
In grade 2 listhesis, sir. So this is for unilateral, sir. Basically, we have done the cases for unilateral symptoms. Unilateral leg pain, sir.
So bilateral symptoms was the exclusion criteria for the study?
No, so only unilateral symptoms with grade 1 and grade 2 listhesis, sir.
Okay, so bilateral symptom patients were not included in the study, I presume.
No, sir, no, sir.
Okay.
I have a question for Vikshit. With all the laminectomy that you guys perform for myelopathy, was it a wide laminectomy?
Yes, sir. Yes, sir. It was a wide laminectomy, sir.
Because there was a really interesting and nice paper from Japan about post-op, C5 palsy, and there they looked at what similarly you looked at in terms of posterior spinal cord expansion and C5 foramen size, etc. And in their article, they basically said the more wider laminectomy you perform, the worse it is in terms of C5 palsy. So in my surgeries, I tend to minimize the amount of laminectomy I do. Predominantly, I tend to do more anteriorly, coming from, doing fusion from the front, which I feel there is a lesser chance of, C5 palsy. But when I'm going from the back, I generally tend to do a less degree of laminectomy, and that's generally even enough for myelopathy, because all you need is a little bit more room rather than excess room. Have you noticed any difference in terms of wider versus narrow laminectomy?
So we haven't compared the wide versus narrow laminectomy, sir. Hello.
Okay.
Yes, sir.
Dr. Vikshit, if I could ask you a question. Although your study was retrospective, but did you have any deciding factors while doing the cases? How did you select the cases in which you decided to do the foramen otomy?
Hello.
Hello.
So I couldn't understand what the question was, sir.
So I said, although your study was retrospective, can you give us some information on how did you select the cases in your study in which you decided to do the foramen otomy and which cases to skip? What was the selection criteria for doing foramen otomy in the cases in which you have done that?
No, sir. This was a purely retrospective study, sir.
Okay. So any take-home message from the study which can guide us in which cases to do the foramen otomy, and so that we may avoid this complication?
Yeah, yes. When there was reduced cervical lordosis, sir, and presence of instability, and focal changes, T2 changes in MRI, sir, and reduced width of C5 foramen, and protruding C5 superior articular process, sir. These were statistically significant parameters which will guide us in doing prophylactic foramen otomy.
Okay.
Yes, sir.
Do we have any other questions?
Yeah. This in continuation to that discussion to Dr. Vikshit. See, in spite of doing cervical foramen otomy, in the group also had palsy, correct?
Yes.
So, if these criteria were present in those cases or were not there, in spite of having a foramen otomy, was there any narrowing of the body and was there any facetal overshooting, and was there any reduced lordosis and instability were present in those cases also?
No, sir. Those criteria were not present in those cases, sir.
Oh, okay. Right.
So.
Okay. Okay. Thank you very much. And to Dr. Sagar Sharma. So what I could see was most of them were grade 1, grade 2 listhesis. I guess what I'm telling is right.
Yes, sir.
And there are only I think 1 or 2 cases of this high grade 3, 4 type of spondylolisthesis.
Yes, sir.
And the complication rates seem to be evenly distributed in your collection of cases, or was it something different in?
Sir, they were more in ischemic group, sir, and less in degenerative. A total of 5 patients post-operatively we found neurological deficits, sir. In that, 4 were in ischemic group, and 1 patient was from degenerative group, sir.
Okay. What will be your take-home message from your study? What would you suggest?
Sir, we can do actually balance the listhesis, and sir, if the listhesis is balanced, sir, then if we do only fusion, then means the result is same as reduction, sir. Whereas if the listhesis is not balanced, it is when the listhesis is not balanced, sir, at that time we should go for reduction plus fusion, sir, because in unbalanced listhesis, sir, there is significant retroversion of the pelvis and the global
Request moderators to move on to the next 5 presentations, please.
And the global sagittal alignment is also affected, sir. So the reduction is also better, sir. And sir, the second thing is that if we reduce more than 50%, then there will be stretching of the nerve roots, and the chances of neurological deficits are more, sir. So if we are having high grade of listhesis, sir, so it's better to reduce less than 50% and do fusion, sir.
Thank you very much.
Yeah. Do we have time for one last question, or shall we move on to the next 3 papers?
You can ask one more question here.
Yeah. Anyone has any questions for the last paper again, or shall we move on to the next question, please? Next session, please. Okay, I think then we will have Dr. Prashant's presentation next. He is speaking on evaluation of cervical range of movement in post-operative anterior cervical discectomy and fusion and total disc replacements.
This is an evaluation of cervical range of motion with inertial sensors. The CROM preservation is an important consideration, and several methods are available, of which DORSA-V is an inertial sensor and it can measure many movements. The hypothesis is that it is preserved in disc replacement while it reduced in ACDF. We had previously validated, ethics approval has been obtained for this, and 2 spinal surgeons have done it at multiple centers. It is standardized measurements, informed consent was obtained, and several range of motions were measured. Variables such as gender, BMI, the level of surgery, age, and surgical procedure was also used. The results are here. There are 23 patients, 13 ACDF, 6 TDR, and 4 hybrid. The lordosis was quite well preserved in both ACDF, hybrid, and disc replacement. While in flexion extension, ACDF, we didn't lose much. However, hybrid and TDR, we did lose them, and it is because of the fact that one of the surgeons who had contributed more on those had 6 weeks of collar. The lateral flexion, in fact, was not lost in ACDF, but lost a little bit in TDR and hybrid, again, because of the collar. Rotation was, in fact, more after surgery in ACDF, while both control and TDR were quite well restored. BMI surprisingly had more loss, particularly in the overweight patients. In age, in fact, younger patients got more in ACDF, while the other ones lost a little bit. Pre and post surgery, depending on the levels, the higher levels, in fact, lost more than the lower levels, particularly in flexion extension. 2 and 3 level lost more than compared to a single level as expected. However, in lateral flexion, the higher levels, in fact, gained flexion, while the multi-level lost lateral flexion. Females actually lost a little bit of flexion extension at 6 weeks. When ACDF was compared to TDR, the ACDF did not lose much of flexion extension or lateral flexion. However, both TDR and hybrid lost at 6 weeks, and this is related to the collar use. So BMI is a significant factor in our cohort, and as demonstrated elsewhere. Age, in fact, there is a reduction in flexion extension as the age. However, the gain post-operative was not changed. Surgical levels, the higher levels, in fact, did not lose much of flexion. Did lose much flexion extension, while the lower levels didn't. Gender, there was a bias for females, and we are not sure why. The important thing about this is that there are conflicting views in the literature as to whether ACDF restores or there is a loss. And in our study, in fact, there was not much of a loss of flexion extension or lateral flexion. However, there is a small size, it's an early time point only, and the long-term usage of collar was a problem, and this needs to be changed in the future at longer-term follow-up. Thank you.
Yeah, thank you, Prashant. We will move on to the next paper, which is outcome of non-instrumented lumbar spine surgery in fibromyalgia, a matched retrospective cohort study by Dr. Shivan Maria.
Good morning, ladies and gentlemen. My name is Shivan Maria. I'm the Manchester Spine Fellow, and I'm here to present to you a study recently done at our center, the Manchester Center of Clinical Neurosciences. Fibromyalgia is a common condition with an estimated prevalence of 4 to 6% in the general population. It is more common in ladies, and it is characterized by widespread pain, fatigue, waking up unrefreshed, and cognitive symptoms. The American College of Rheumatology first defined a criteria to diagnose this condition in 1990, and it has recently been updated in 2016. You can see the diagnostic criteria on this slide. However, this is a bitterly controversial condition, with some authors suggesting that it may be a somatoform or a functional disorder. As surgeons, we tend to assume that patients with fibromyalgia have a poor surgical outcome and high analgesic requirement post-operatively. However, at least in spinal surgery, there is very limited literature available on this topic. With this background, the aims and objectives of our study were to determine the outcomes of non-instrumented lumbar spine surgery in patients with fibromyalgia and to compare the results with a matched cohort of patients without fibromyalgia. Ours was a retrospective matched cohort study done between 2015 and 2019, where patients with fibromyalgia undergoing a single-level elective lumbar decompression or discectomy to help alleviate symptoms of radicular or claudicant leg pain were included in the study. We excluded patients who had underwent emergency surgery, revision surgery, or patients whom we could not find a matched control. The strength of this study was in the matching. For each single patient with fibromyalgia, we had a patient without fibromyalgia matched in terms of age, sex, BMI, ASA grade, smoking status, and their preoperative COMI scores. This was done to reduce the effect of confounding factors on our results. The outcome measures that we examined were the leg pain and back pain VAS scores and the COMI score. A comparison was done between preoperative and postoperative scores at 3 months within each group of patients and between the two groups, which is fibromyalgia and non-fibromyalgia. Here we can see that the preoperative differences between the two groups was that the back pain significantly higher in patients with fibromyalgia, as one would expect due to the underlying disorder. At 3 months post-op, we can see that the leg pain VAS and the COMI score was significantly better in patients without fibromyalgia. Also, in terms of a change in the score from preoperative to postoperative, we can say that there was a greater improvement in patients without fibromyalgia. Therefore, to understand the numbers, what we know was that leg pain VAS was significantly more improved in patients without fibromyalgia. Back pain VAS was higher in patients with fibromyalgia and not changed by surgery. And the COMI score was again similar between the two groups to start. However, there was a greater improvement in patients without fibromyalgia, which was not statistically significant. The limitations was that this was a retrospective cohort study. However, we did collect the data prospectively, and each patient was matched to a control. There are low numbers. However, this is once again because of our strict exclusion criteria. The follow-up was short-term. However, once again, studies tend to show that the maximum effect of these surgeries is at the first 3 months. There is, however, a possibility of cognitive bias. To conclude, following non-instrumented lumbar spine surgery, there was no significant difference in improving back pain and COMI score between the two groups. However, there was a diminished effect in improving leg pain in patients with fibromyalgia. We believe this would be useful in preoperative counseling for these patients. These are my references. Thank you.
Thank you, Dr. Maria, for the unique study. So we will come back to questions to you in some time. We'll move on to the next paper, which is again, I feel is a good association, diabetes mellitus and development of lumbar canal stenosis. So Dr. Ghanshyam Kakadia is going to look at the relevance of these two conditions. Thank you.
Good morning, everyone. My presentation is on diabetes mellitus and its effect on lumbar canal stenosis. Diabetes mellitus and lumbar canal stenosis both are common conditions. Diabetes is a multi-organ disease that affects many types of connective tissue, including bone and cartilage. Our study aim was to determine the association between type 2 diabetes mellitus and severity of lumbar canal stenosis. It was a retrospective study, and lumbar canal stenosis patient included as per inclusion and exclusion criteria. Total of 398 patients was included in this study. Group A include patient without diabetes mellitus. Patients with diabetes mellitus were divided into two groups. Group B, a well-controlled group, and Group C, poorly controlled patient. Group B and Group C subdivided as per duration of diabetes mellitus. Results shows the demographic data of group did not show any difference except age. There was no difference between number involved level between the groups. Functional outcome assessment was done using ODI and switch spinal stenosis score. Group B2, C1 and C2 had higher average switch spine stenosis score and ODI. The severity of lumbar canal stenosis was significantly related to the duration of diabetes and poor control of diabetes. This is a lumbar spine MRI of 56-year-old controlled diabetic female patient, and mid-sagittal view shows L4, L5 disc bulge with stenosis, and axial scan shows L4, L5 and L5 S1 disc bulge, ligament flavum hypertrophy, and central and lateral recesses stenosis. In this lumbar spine MRI of 58-year-old uncontrolled diabetic female patient, mid-sagittal view shows lumbar degenerative disc with L4, L5 and L5 S1 disc bulge with stenosis. Axial scan shows L4, L5 and L5 S1 disc bulge, severe ligament flavum hypertrophy, facet joint degeneration cyst, and severe central and lateral recesses stenosis. 30 cross-section per group were evaluated for histopathology. Ligament flavum elastin fiber loss was significant in diabetic group. Longer duration and poor control of diabetes patient had more significant elastin fiber loss found. In this first image, MRI and microscope slide of 58-year-old non-diabetic female shows normal elastin fibers. Second image shows a 60-year-old female with uncontrolled diabetes mellitus of longer duration, and lumbar canal stenosis shows severe lumbar canal stenosis with moderate loss of elastin fiber. We concluded that there is a positive relationship between diabetes and lumbar canal stenosis. A longer diabetes mellitus duration and poor control of diabetes could aggravate lumbar canal stenosis. Thank you.
Thank you, Dr. Ghanshyam. The last fee paper for this session is going to be clinical and radiological outcomes in patients of Parkinson's disease undergoing instrumental lumbar spine surgery for spinal disorders by Dr. Ashish Gupta.
Good morning, everyone. My topic is clinical and radiological outcomes in the patient of Parkinson's disease undergoing instrumented lumbar spinal surgery for spinal disorder. Parkinson's disease is a disorder of basal ganglia affecting approximately 1% of the population over the age of 60 years. Parkinson's disease is a degenerative movement disorder of the central nervous system characterized by tremor, rigidity, and bradykinesia. Additionally, Parkinson's patients often develop stereotypical postural changes, including stooped posture, dropped head, and flexed trunk, hip, and knee. In some patients, postural changes manifest as more disabling spinal deformity, such as scoliosis, endocolis, camptocornia, PISA syndrome. Abnormality of the spinal alignment shift the patient center of gravity, forcing abnormal spinal loading, which in turn may accelerate normal and age-related spinal degeneration. These biomechanical and neurophysiological changes place Parkinson's patient at increased risk of spinal deformity and other spinal conditions. Aim of our study was to describe our experiences of clinical and radiological outcome in the Parkinson's patient operated for degenerative lumbar spinal surgery. This is a retrospective study included instrumented surgeries for spinal disorder in patients with Parkinson's. Clinical and surgical data, including revision surgery, were collected. Assessment of functional outcome at last follow-up was done with the modified Orthopaedic disability index, and spinal balance was assessed on AP and lateral plane X-ray of spine. Various sagittal balancing parameters, sacral slope, pelvic tilt, pelvic incidence, lumbar lordosis, and PILL mismatch was measured. Total 13 patients included with Parkinson's disease who underwent surgeries for lumbar spine disease. 7 female, 6 male, mean age 66.47 years. Median follow-up was 13 months approximately. 9 patients had at least one associated medical comorbidity along with Parkinson, indicating medical treatment. 1 patient presented with a sequel of failed previous surgeries. BMD average score was minus 2.29. Among them, 8 patients were osteoporotic, 4 osteopenic, and 1 was normal. 10 patients underwent fusion procedure and 3 patients percutaneous fixation was done. At a mean follow-up of 12.84 months, we noted surgical complication in 3 patients, adjacent segment degeneration in 2, and proximal junctional kyphosis in 1. These adjacent segment degeneration and this one proximal junctional kyphosis. PILL mismatch was 19.69 preoperatively, 16.38 postoperatively, and 15.15 at the final follow-up. At post-op PILL mismatch was within limit 0 to 10 in 4 patients, moderate 10 to 20 in 4 patients, marked 20 to 30 in 5 patients. All the 3 patients who have post-op complication during follow-up had marked PILL mismatch. The rate of surgical revision was in 2 patients, both had adjacent segment degeneration, and 1 patient under observation with proximal junctional kyphosis. Modified ODI score was minimal disability in 4, moderate in 7, severe in 1. 1 patient was crippled and no patient was bedbound. Case examples: 54-year-old male presented with the low back pain with bilateral radiation and severe claudication, non-patient of Parkinson's disease, diagnosed as grade 1 degenerative spondylolisthesis L4, L5 with gross compression. PILL mismatch was more than 20. At the 4-year post-op follow-up, he had adjacent segment degeneration at the L3, L4 with grade 1 spondylolisthesis. Then we did the extension of fixation with fusion. Second case, 70-year-old female decompression and instrumented fusion done at L3, L4, L5 level elsewhere. Presented after 5 years of surgery with the recurrence of back pain. Diagnosed as adjacent segment degeneration at L2-3 with gross sagittal imbalance. We have done the extension of fixation and fusion, and we corrected the sagittal imbalance. Conclusion: patient with Parkinson undergoing lumbar decompression and fusion have high complication rates. Preoperative PILL mismatch and osteoporotic bone and long lead to poorer outcomes. Surgery, single center study for number of patients. These are references. Thank you.
Thank you, Dr. Ashish Gupta. Are there any questions for Dr. Prashant Rao on his paper on the evaluation of cervical range of movement between ACDF and TDR? Anyone has got a question?
Dr. Prashant, what was the longest follow-up in your study?
It's only been 6 to 8 weeks. That's the first part of the study. So we're going to do it at 6 months, 12 months, and 24 months.
So I presume at that point of time, you are possibly looking for some complications like HO complicating the range of motion in TDR.
Possibly. More likely is that the range of motion is probably higher in TDR compared to just ACDF.
So in one of your slides, you mentioned that for one particular range, I think it was lateral flexion, there was more loss in the TDR group as compared to ACDF. Is it so?
Yes.
Yeah. So for both flexion extension and lateral flexion, we had loss in TDR, but that was because one of the guys who contributed more for TDR had kept them in collar for 6 weeks. And hence he's now changed after the study to only keep them in a collar for 2 weeks.
Okay. I have a comment to make, Prashant. Hi.
Hi.
Now, you did say that it is actually a small sample and it's a very early results that you have put out. So you've not yet looked at the change in outcomes as to axial neck pain, how it actually translates, how your salvage of ROM translates into preservation of, reduced axial neck pain or clinical or better clinical outcomes. This is a purely radiological or a movement-based study, isn't it?
Correct. At the moment it is, but both of us collect data on VAS scores and neck disability index. So that will be included at longer term follow-up in terms of whether it improves. And I think that's a very important point. One of the important points for us was how much of movement do you actually lose doing an ACDF? And I think that's a very common question you get asked. 1 or 2 levels, how much I'm going to lose?
True.
And the important thing for us was in an ACDF, you haven't actually, global loss of movement was not actually shown even at 6 weeks. So we're hoping that even later on, it's going to be that they actually don't lose the whole range of movement because the other discs actually do more movement. And I think pain is also an important contributor for loss of range of movement.
Okay. Dr. Karunakar, do you have any questions for Dr. Prashant Rao, or do we move on to the next presenter?
Nothing, Dr. Raghavendra.
Okay, so any questions for Dr. Shivan Maria, please? Yeah, Dr. Maria, you want to ask a question to Dr. Prashant?
Yeah, Dr. Rao, I just wanted to ask, in your study, are you routinely plating your ACDFs, the ones in which you're putting cages, the ones you're fusing?
So I do, but generally it is a small plate. So I use an integral plate.
So like a 0P?
The cage. Sorry?
Like the 0P, like the Depusynthese 0P.
Correct. Something of that sort. I use one called as a Delta cage, and that's got a plate that is attached to it. The other guy uses generally an integral screws. So 2 screw kind of a thing, like a 0P. So don't use a very long plate.
Okay, thanks.
Any questions to Dr. Maria now on his paper on fibromyalgia and single level lumbar surgery?
Dr. Maria, I've got a question for you. It's a very interesting topic, fibromyalgia.
Yeah.
I generally think of it as a basket of, I don't know anything kind of patients. When you don't know what you're looking for, then you put them as fibromyalgia. Now, I've got an interest on thing called as myalgic encephalomyelitis. I don't know if you know anything about it. So myalgic encephalomyelitis, fibromyalgia, is a group of patients. And many of them have got Ehlers-Danlos syndrome that the rheumatologists or the clinicians don't actually look into. And I've found that their outcomes are much worse in terms of their pre-op pain, post-op pain. Did any of these fibromyalgia patients, were they diagnosed by a rheumatologist, or did you guys rule out other causes such as EDS?
So the way fibromyalgia is diagnosed and coded in the UK is via the patient's GP and rheumatologist who have to fulfill the ACR 2016 criteria. This is essentially, our study was retrospective. So that means that I haven't seen these patients obviously physically, but we're picking up on their ICD codes as and when they've been operated. But we can go back and look into whether they've been coded for Ehlers-Danlos. But like I said in the presentation, the baseline characteristics between the two groups were pretty much identical other than the back pain score.
No, you guys have done a wonderful study, beautiful study. Now, I was just curious as to if you put the codes, I've got about 50 to 100 patients of EDS, which are in severe state of myalgic encephalomyelitis. They'll tick all the boxes that you had on your fibromyalgia. So they've all been told to be fibromyalgia, and then over 10 or 15 years, and then have got a new diagnosis. And if you look at even myalgic encephalomyelitis, they've got a diagnostic criteria, and that's like another 50 added things.
Yeah.
But anyway, that was very interesting though.
Yeah, I have a comment to make, Dr. Maria. So ultimately, your study actually tells us whom to exclude or what to explain to the patient, isn't it? Yes. In terms of prognosis, the prognosis of the surgical outcome. Yes. The patients come to us looking for a lot of boxes to be ticked. So in your study, in fact, it proves that there are a few things that we have to explain that are not going to get better. Yes. In spite of the surgery. Yes. And we have to pick and choose what we explain to the patient. But it's a very unique study. I've not come across a paper in this.
Yeah. Yeah. So
you matched your patients very well.
That was, again, like I said in the study, we didn't have very many numbers. There's only 24 in each group, but the strength was the matching. And just coming back to your point, essentially what we felt at the end of the study was that if a patient with fibromyalgia comes to us and with leg pain, with a significant pathology on their scan, what we can tell them is that we will make the leg pain slightly better, but it is not the same as a patient without fibromyalgia. And that has to be considered when you're talking about risks and rewards of surgery preoperatively.
Yeah. Any further questions for Dr. Maria, Dr. Karunakaran, or Dr. Suri, or any of the other participants?
Yeah, there's one question. There's one question in the chat box for Ashish Gupta.
We'll come to Ashish Gupta next. We'll come to him next.
Just a small comment, Dr. Shivam, excellent study. But the literature shows that fibromyalgia patients do have some other psychological issues, might have some other psychological issues as well. So I think in your section on preoperative demographics between the two groups, it might have been a better option to consider preoperative psychological scores also between the fibro and the non-fibro group, just to lay out whether that could be a confounding factor in poorer results in the fibro group. Do you feel so?
Yeah, absolutely. I think cognitive symptoms and behavioral symptoms is a big part of the fibromyalgia disease complex. And we all know that the patient's psychology does affect outcomes and surgery. So that's quite true that it could. But another thing that we find usually with patients with this problem is that they often come seeking surgery. They come seeking medical attention. They want intervention. So you would hope that if they have come wanting that, then they would want a good improvement. But I completely agree with your point. Yes, a psychological evaluation would be useful. Unfortunately, we don't routinely do that on our patients. So it's data which I would probably not be able to come by.
Can we move on to the next paper by Dr. Ghanshyam? Any questions on his paper on diabetes and lumbar canal stenosis?
There is a question. I'm Dr. Karunakaran speaking.
Yes,
Dr. Ghanshyam, this is regarding the elastin content. I understand that you would always deteriorate even in a non-diabetic patients. Do you agree with my comment, or you have a different opinion?
Yes, sir. Because
maybe we lost it.
Hello. Yes, sir. I can understand, sir. Due to the old age of the patient, the number of elastin fiber are lesser in the older groups. But as a comparison, in diabetic patient and uncontrolled diabetic group, we have found elastin fiber loss is a significant elastin fiber loss was there, sir.
And I have a query here, Dr. Ghanshyam. You mainly looked at the thickness of elastin, but not commented upon the bony stenosis, which actually has got a significant role to play. So this is not entirely ruled out. We can't entirely attribute the same toward diabetes, isn't it?
Yes, sir. Actually, the purpose of our study was only functional outcome, and this study is 5 years of duration. It was started before my MS. So as per our professor guide, professor study.
Last 1 minute we have to wind up the session. I'll take one. There's one question for Dr. Ashish Gupta.
Yes, sir.
Dr. Dylan. He has posted it here. How did you rule out muscular weakness component for sagittal decompensation in Parkinson's patients?
Sir, actually hello?
Yeah, go ahead.
Sir, actually that all the patients, what we are included, that already the Parkinsonism diagnosed patient and they are all already on the treatment.
No, they want to know how did you rule out muscular weakness as a cause of sagittal decompensation? Because you have shown some pictures where the patients have decompensated sagittally, isn't it? So they want to know how have you ruled out muscular weakness component?
Hello?
Yeah, go ahead. Go ahead.
Hello?
Yeah, go ahead.
Am I audible, sir?
Yeah, you are. Go ahead.
Sir, actually we included all the patients who are already diagnosed with the Parkinsonism disease and they are already on the treatment for the Parkinson's disease since a long time. And they are already actually whatever the complications, those are all that adjacent segment degeneration and the kyphosis.
Okay, if there are no further questions, I think we will wind up the session. We thank the organizers, all the co-panelists, and the free paper presenters for an excellent job. Dr. Karunakaran, if you have any closing comments to make, or even Dr. Tarun Suri, please.
Yeah, this is very interesting because they considered some of the day-to-day problems, which is very important to be highlighted.
Correct.
Right, from fibromyalgia to Parkinsonism. And good that they are continue. I hope they will continue the study and come up with more details, and wish them good luck. And in spite of all this COVID, there's lots of enthusiasm from the presenters. Nothing has stopped them from presenting. I wish them all good luck and continue their good work. Thank you.
Yeah, Dr. Suri.
Excellent papers. Congratulations to all the presenters. So very, very interesting papers, out of the box thinking. And I sincerely hope to see long-term results of many of these in the subsequent ASSICONs. Congratulations.
So we wind up this session and hand over to the organizers. Dr. Ankur, if you want to take over. Thank you.
Thank you so much, moderators. I mean, you are, the organizers' dream come true. Finishing on spot, involving everybody, interacting with some great papers. And thank you so much, Dr. Karunakaran, Dr. Raghavendra, and Tarun. Pankaj, thank you for helping with the previous session. So we are going to now move on to the next session. It's a cracking session from our industry partners, and they're going to be talking about some cutting edge technologies, what's coming new, what can you expect in the what is new in the field of spine surgery, and how they can help us in managing our clinical problems in the coming days. So we are going to start with the first lecture. The first lecture is from DePuy, and they have asked Dr. Ayush to sort of represent them. And Ayush is speaking on my experience with Viper Prime. So over to you, Ayush. Can we start? Ayush, slide please.
So today we'll be talking about guide wireless minimally invasive pedicle screw, which is a new kid in the town, a completely new technology. So this was one of our cases. If you see here, what has happened is the tip of the tap has just broken in. So while we are trying to remove the guide wire from the tap, the part of the tap broken and it is just blocking our entry to the pedicle screw. we tried putting the Jamshedi again or dislodging it with a another tap, but that didn't work. So we had to put a lanky probe and just dislodge the broken metal. And so we could get the trajectory exact what we wanted, and we could get away with the fixation. So anyone who has ever done a minimally invasive screw fixation will tell you that one of the two most dangerous thing about doing them is the guide wire and the migration of guide wire through the tap. If you look at the literature and look at the complication of percutaneous pedicle screw fixation, it could be as simple as this broken guide wire in the pedicle screw to migration of the pedicle screw, this migration of the guide wire, which is very, very common, especially if you are putting the screw in a osteoporotic fracture or osteoporotic bone. It could be as complex as this abdominal aortic injury, which happened due to the migration of the guide wire anteriorly, which has damaged and caused the aneurysm of the abdominal aorta. Of course, not our case. This is from one of the case reports. So if you look at the comprehensive literature review at complications associated with guide wire use in spine surgery, the risk and the complication can range from 0.4% to 14.8%. The complication includes guide wire fractures, just like the one we saw there. It could lead to CSF lead. If you have punctured the dura, it could lead to postoperative ileal, to infections, or some of the other complications we just spoke about. Now, this is where this innovative system comes into play. It is called Hyperprime. It is launched by Defiosynthesis, and it is basically a stylet-based minimally invasive system. So this is how the system looks like. So this is the stylet which comes out of it, and this is the control for the stylet. So it is a novel technique for putting the percutaneous pedicle screw, which eliminates the need of guide wire or the Jamshedi needle. This video we'll see how it exactly works. So this is the control for your stylet. So as you turn this knob, the stylet comes out, and this is calibrated. It can go from 1 millimeter to up to 6 millimeter. And as you turn it in the other way around, the stylet goes in. So it is surgeon's control, and you can choose depending upon the situation and scenario. So let's see how it exactly works. This is a small video. So the entry point and everything is like a traditional minimal invasive screw. This is like the dilators which comes in. You put on the dilators. Once you have put on dilators, then you put the screw with the stylet system inside. And this is a real-time video. We just to make the cortex, I'm using the hammer just to get the small entry inside the pedicle. Once I have done that, I'm just rotating the knob to get the stylet system out. So this is what I'm doing, as you can see here. Once the stylet system is out, it is calibrated, so it can go up to 5 millimeter. I'm just trying to get a hole in the pedicle, and this is the shoot. So I'm the lateral border of the pedicle. I'm going enough so that I get a hole of the pedicle. So now I have the hole of the pedicle. At this stage, I'll get another shoot. So I'm near the medial border of the pedicle by this time. So I'll just get a lateral shoot to confirm if laterally it is the same case or I need to change my trajectory. So it looks like okay. So we'll go ahead with putting the pedicle screw. At the same time, I could slightly redirect my pedicle screw at this stage. And then once I am good about the trajectory, I'll go all the way in. But before I put the screw finally in, I will reduce the stylet so that the stylet doesn't go and hit the opposite cortex. This is what I'm doing here. So I have taken out the stylet back, as you can see here. And then we'll put the screw in, and then we take out the system. So this is how it looks like at the end of the day. So this is, as you can see here, this is how it looks with the dilators, and this is a bare. If you also remove the system and the dilator, this is how it looks like. So you'll appreciate that it's a all reduction screw. So the throughout the length of the attachment is a reduction screw. So not only that, if you, for any reason, if you feel like augmenting the screw with cement, if it's a osteoporotic fracture or the hole is not good, you don't really need to do anything. You just introduce the system, which is inbuilt with the screws and adapters, and you can put the cement. The other thing is you don't need to have a separate incision like some of the other system in market today. You can pass the rod with the same incision without even having to bother about a separate incision altogether. So if you compare a traditional Jamshedi based or guide wire based system to this guide wire less system, what you will see that you are spending more time in targeting and placing the screw. That means you are likely to be more accurate, and the same time, some of the steps like tapping and guide wire, putting the guide has gone out, so you are likely to be faster. So this is one of our cases, a lytic listhesis, which we operated, and we did it in lateral position because we wanted to do a OLIF in this case, and this is how the OLIF cage went in, and then we use this MIS system to put the screws, and you can see this is how the wires are going with the stylet jetting out, and as we go in, we decrease the stylet so we don't puncture the apotic cortex. And this is what we got in the end. But one of the best part is we didn't have to flip the patient in this case. So normally if you're doing a OLIF, you flip the patient, paint it, redrape it, and then put the screws. But because of the simplicity of the system, even although these were non-navigated screw, we could do the screw placement in the lateral itself. So it was a single position surgery. And if you look at this is the post-op X-ray showing the position of the K and the screw, and we got a decent alignment, and the screw looks pretty decent as well. So because of the low profile of the screw, even this is the incision for the OLIF cage 2 centimeter. If you look at this incision, the start incision are very small because this system again has a very low profile head. And this was another case, a degenerative scoliosis, where we combine the two systems. We use at the top and the end, we use this guide wire less pedicle screw because these are all reduction screws. So basically, I'm using them as a reduction screws. And in between, we use the regular MIS screws. So what it allowed us to have a very good gradual reduction of the rods. Even though the rods were contured nicely, still we didn't have a problem. And this is where we started in this case, and this was the final reduction with the system and the OLIF cage. The other small thing which is good about the system is, unlike a guide wire, which is Jamshedi or a guide, is very flimsy, and if you need to change the trajectory, sometimes it could get very tricky. This is like a full solid system behind the stellate. So it is very easy to change the direction if you wish to. So this is how just a simple dropper hand can really help you change the direction and get a better trajectory if you are planning to put the screws. So at the end, I like to conclude that guide wireless MIS pedicle screw, which is the fiber prime in this case, is a novel technique for putting the percutaneous pedicle screw, which eliminates the need of guide wire, making it much safer than traditional MIS screws. Thank you. Thank you so much.
That was quite a nice talk, Ayush. Thanks for the same. So, have you faced any problems regarding the skiving part as you take the entries with the guideless wire system? Is that a problem, and is it a problem to really find your way again back once you've taken off your instrument when the wire is not there? Is it really a practical problem?
No. Actually, it is better. Like the good part about it is solid. The tip is better than most of the Jamshedi which we need. It's a very solid tip, so it won't skive off. Unlike what you, especially if you are doing a sclerotic pedicle, we all know when sclerotic pedicle, especially listhesis and everything, because the pedicle is sclerotic, and you got to put the Jamsedi, they are sometimes not very strong enough, and they don't go in. But here, the good part is the tip is very solid, and you have the hold of the full weight of the screw behind you. So anyone like us or who has graduated from a open system to MIS will find it better in their hand, because it gives you a feedback while you are doing it, unlike a flimsy Jamsedi. So in those scenarios, it is better. The only caveat to it is you have to pre-decide the length, because the stylet is anterior. If you go two-way in, you might damage something anterior. So we started with using the CT scan preoperatively to define the length, because length you should be very, very specific. Otherwise, you can damage something anterior to the body.
All right. So one of the cases you showed that you have done the case in a lateral position, you've done an OLIF and then put the screws as well. Do you see any challenges in this system as far as rod placement is concerned? And is it easy to do a multi-level fusion in the lateral position along with the rod placement, or is there a challenge there, especially on the side which is on the down, which means the right side?
Yeah. So always the single lateral position are challenging, as we all know. So there are a few good things. So why we chose this system to do a lateral position, because the screws are all reduction screw. For example, if you want to reduce the rod in a MIS system, no matter which system you use, you're using a reducer. So what a reducer does, it reduces the screw to the rod. So that is always a bit of problem. But here the whole system is like a reduction screw. So you're using all reduction screws. So your screws are reducing the rod to the screw. So it is very easy to do a multi-level system with this compared to regular system. But even we have not tried it multi-level in a single position. Right now, we have only done single level in a lateral position, because multi-level could be very, very tricky. So I will suggest maybe over a period of time, as we get more confidence, we can do multi-levels.
Sure. Thanks for your talk, Ayush. Are there any questions from the panelists for Ayush, or shall we move on to the next talk? Is there any question? All right. If there's nobody, then thanks, Ayush, and we'll move on to the next speaker. The next speaker is speaking on behalf of Stryker. It's Mr. Mayank, and his topic is breakthrough revolutionary technology in deformity correction. So can we have Mayank's slides, please?
Was one of the first members of the team that developed the MESA spine deformity system. One of the main goals of designing the MESA system was to make it very versatile, simple and complex deformities, degenerative deformities, and also to make it very user-friendly, low profile.
I have been a MESA user, I think, since 2008. Over the years, I've realized that there are some things that make this product superior to some of the other products. The surgery is as efficient and short as I can make it, with a combination of the skill and experience that I have and the technology that the MESA system brings in.
When I first started out in practice, I literally used almost every system that was out there. Then fortunately, I came across the MESA system, and with the other systems, most of the time involves attaching additional equipment to perform the derotation after you do certain corrective maneuvers. But with the MESA system, I am literally correcting all three planes of deformity simultaneously.
I take care of a lot of patients who have scoliosis at a very young age. They're small, they're big,
in, their bones aren't very strong. And I was looking for something that solved some of the problems that we have. This system has solved enough of the challenges that I face that I feel like it's the ideal solution in my hands to give my patients the best care that I can.
The system brings together all the elements that are needed for a very synchronous, harmonious, three-dimensional correction of spinal deformity.
With scoliosis, they have a certain deformity that whether they state it overtly or not, I think they're self-conscious about the body image. And scoliosis, there's a considerable amount of rotation of the spine. We may make their spines straight, but if we can untwist them and decrease the asymmetry in the back and in their bodies, they are much happier.
Many of our kids who were really good athletes and participating in things beforehand are still able to do those things and are so excited that they can get back to the things they love to do.
You name it, there are children doing it. So I have archers, I have gymnasts, I have cheerleaders who are the flyers in cheer, I have divers. All of these children who have undergone a fusion with the Mesa 2 and the rail and have returned to their activities that they love to do.
Life before surgery was quite challenging. I suppose you always kind of have that in your mind, like, oh, I have scoliosis, I have something wrong with me.
I would wear clothes that were too big for me in order to hide it because I didn't want to tell anyone because I didn't know how anybody would react. And I just wasn't really super happy with that, and I felt like I couldn't be myself.
Once you're diagnosed, it is tough and you're like, oh my God, I have scoliosis, but it can be fixed. And that's one thing that I kept, and my parents kept saying to me, it can be fixed.
Spine surgery has allowed me to continue what I was doing before, but do it better because now I'm not hiding in the brace, and I feel like I'm more outgoing and I'm not afraid to talk to new people or have to explain about the brace and stuff.
Surgery was December 18th. Christmas was a week later. 1 week later, and she's enjoying Christmas with us at home. 20 days later, she was at school full time. She's a competitive swimmer. And watching her participate in her first long course meet after surgery at 6 months, I never thought she'd be swimming a long course meet at 6 months. And at the state level, participating in finals. She's been able to do yoga. She picked that up on her own, and she's doing her yoga with her fused back thanks to your screws and your technology.
A scar is a tattoo with a better story. That scar is a story, and it shows so much more to you.
I would like to thank the people that have created this and gotten it to the hospitals and stuff for helping people like me.
Thanks for giving me such an amazing life and quality of life.
I'm Dr. Oheneba Boachi Ejeyi, orthopedic surgeon, professor of orthopedics, Weill Cornell Medical Center, and chief of the scoliosis service at the Hospital for Special Surgery. Today, what we did was to operate on a 15-and-a-half-year-old girl who has had congenital scoliosis with pelvic obliquity. And this patient was born with an absence of the lower end of the spine and caudal regression syndrome. She also had contractures and abnormalities of her legs, and that has required disarticulation of the left knee, and she uses a prosthesis to walk. She was known to have scoliosis when she was about 6 years old, and it did remain stable, but over the course of time, it did progress, and to the point where she is having difficulty with sitting. So when we saw her a few months ago, she had 135-degree scoliosis, which is a very severe deformity of the spine, involving the entire trunk, 130 degrees with pelvic obliquity. And the patient also had a very severe caved-in chest, which reduces the trunk, the thoracic volume. And this was what I think was affecting her breathing also. So the challenge was to realign her spine and the pelvis and also restore some volume to her chest cavity. Now, in addition, she also has a tethered cord. She's got a fatty tumor at the base of her spinal cord, which is holding on to the base of the spine, so it's not moving freely. Now, neurologically, she was okay. Now, to be able to correct her spine, there's always the danger of causing further neurological deficit like paralysis or bowel bladder problems, especially with the tethered cord. So we consulted with our neurosurgical colleagues to release the tethered cord. And that was done at the same time as the spine operation for the scoliosis. So anatomical pedicle probing technique was utilized, identifying at each level where the pedicle screw should be placed, and then all was inserted at the base of the pedicle for thoracic, followed by a probe into the lumen of the pedicle, and then choosing the right distance and level for pedicle screw placement. A probe was then placed to assess the intact pedicle walls, especially the medial wall and the lateral wall. And then subsequent to that, followed by a tap. Patient had soft bone and also small pedicles. So the tapping was done at these levels to choose the right size of pedicle screw without breaking a wall. Polyaxial and uniplanar screws were used. In the areas where we were not doing any derotational correction, polyaxial screws were used. And in the lumbar spine where derotation was going to be performed, uniplanar screws were used. The iliac crest was exposed over the outer table, and the posterior superior iliac spine removed and a probe inserted into the iliac tables. This was followed by tapping and placement of a polyaxial screw, usually measuring about 6.5 diameter and 70 to 80 millimeter in length. The cobalt chrome rods that were used, 5.5 millimeters, was pre-bent in the anatomical physiological plane to restore normal kyphosis and lordosis. So the distal anchor of the rod to the iliac screw was obtained, and then following that, multi-axial reduction jacks will be placed over the iliac screws to establish a lumbopelvic foundation. But because of the significant abnormality of the patient's lumbar spine, sublaminar cables were added to reinforce the distal fixation on the left side. So here we have both pelvis fixed, secured, and then transversely connected with a natural bridge transverse connector. So we have now in completing our distal sacropelvic fixation, which will then serve as a solid foundation to translate the spine. So multi-axial reduction jacks are placed, and here we're using the cricket extenders or the reduction jacks extender, which aids in working around the soft tissues, and then advancing the reduction jack to the level of the screw. And you can see how the rod stays above the rest of the spine. The multi-axial reduction jacks are now connected to each other with a transverse coupler, which allows for derotation. And you can see the derotation maneuver that's just accomplished. This helps with the lumbar spine derotation. Reduction jacks are now advanced to seat the rod. So the spine comes up to the rod, spine is derotated and now being translated posteriorly. And this is done sequentially from distal to proximal, and going back and forth, translation can be done from one screw to the other until all the screws are brought into approximation with the pre-bent rod. So the derotation maneuver is held in that position. The rod has been translated, moved from right to left, correcting the pelvic obliquity. and then the translation of the spine to the rod done sequentially from one level to the other. So on the convex side, again, multi-axial reduction jacks are placed using the cricket extenders. So at each level, you have to make sure that the reduction jacks are fully seated. If it's not fully seated, one will not be able to do a partial locking of the rod to the screw. Now, if there is, here we wanted additional correction of the sagittal deformity, so we back out the reduction jacks at the apex of the lordosus. Now, in situ benders can then be utilized to bow the rod, i.e. in situ bending. So here we're producing some kyphosis into the rod. With the cobalt chrome rod, it has less memory compared to, say, titanium. Therefore, bowing of the rod or in situ bending can be performed over several levels. With the reduction jacks backed out, the rod can then travel through the reduction jacks and also provide the needed correction. So here we're fully seating the reduction jacks at all the levels. And after that, the partial lock-hold device is used to partially lock the rod to the screw at each level. Now, another maneuver that you also see here is that the partial lock-hold, when it gets hold of the screw head, and if it's a monoaxial or uniplanar screw, one can also try to get some derotation. Partial locking is achieved, and all the reduction jacks are now removed. This is the advantage of having reduction jacks as opposed to, say, reduction screws, which then has to be manufactured separately or differently. And following the partial locking and removal of the reduction jacks, full locking that can then be achieved. With the full locking in place, one can compress or distract if there's a need for additional correction. We had achieved most of the correction that we thought we were going to get in both the coronal plane for scoliosis correction, sagittal plane for kyphosis restoration, and therefore there was no need for additional compression or distraction. And bone graft obtained from the iliac crest supplemented with the local bone from the spinous processes, and allograft is also added to achieve fusion. The final product, as you can see, the scoliosis here of 130 degrees. This is probably about 35 degrees now. It's nicely corrected from the 130 to 35 degrees with all the fixation points in there. And then if we look on the side view, you can appreciate the restoration or the roundness of the side view or improved kyphosis between this x-ray and that x-ray. So not only did we correct the scoliosis, but also improve her side view, which hopefully will give her more volume. So in a nutshell, we basically did what we would normally do for a neuromuscular scoliosis with pelvic obliquity, truncal imbalance, and achieve a three-dimensional correction with multi-placed anchors in the vertebra, capture manipulation technique, cantilever correction, derotation, and then translation of the spine to a pre-bent rod to achieve scoliosis correction and restore thoracic kyphosis. And then, of course, we did a bone graft, and which is the hallmark of the operation, is to achieve a fusion.
Thanks, Mayank. That was a very interesting surgery to see with the great Dr. Boachi. So I'm not going to ask you any technical questions. What I'm going to ask is, can you just let us know in 2 lines why MESA scores over other systems? What's the biggest USP about this system?
Yeah, thank you, Dr. Nanda, for this opportunity. So MESA system actually gives it's a low profile system, first of all, and unlike other systems, it actually distributes the load when the surgeon is doing correction maneuvers. So that's the biggest advantage, not putting pressure on just one point, but distributing the load. And especially in adolescent scoliosis, where patient is really thin, these low-profile system is a breakthrough technology, especially in the cases of skinny patients where screw actually protrude. So MESA is really convenient and easy to use instrumentation, especially the cricket system, which allows around 27 millimeter of reduction.
Okay, that's great. Are there any questions for Mayank or Dr. Gautam?
Yeah, Mayank, I think the system is very nice, and I think this thing. How does it work in the Indian market in terms of cost? How does it compare to the Indian instrument systems? How does it compare to the Korean instrument systems and to other American systems?
Yeah, thank you, doctor, for the question. So MESA is actually a proprietary and a premium technology, and so therefore we have priced premium currently. However, it is accessible in India, and we have around 6 to 7 distributors across India who are doing the surgeries. And especially we have some prominent centers in North India and South India. The doctors have started to adopt the technology, and they have seen really good results.
No, I'm sure. I mean, having seen Dr. Boachi, of course, he's a master, and it's a different thing altogether. But the outcome of that surgery was fantastic. So, and the ease with which he was correcting was incredible. So we are very happy to learn of this technology. In fact, and in Bombay, I was not aware that such an instrument system exists. So it was good for us to learn this. Thank you very much for showing us, and best of luck with your sales on this.
Thank you, doctor. Have a good day.
All right. So we move on to the next presentation. The next presentation is being done by on behalf of India's Medical Technologies. The next presentation is by Dr. Aditya Engalalekar. He's speaking on India as a global R&D and innovation hub in the spine domain. So can we have Aditya's slides on, please? Over to you, Aditya.
Good morning, everyone. My name is Dr. Aditya Engalalekar, founder and CEO of India's Medical Technologies. The topic of my presentation today is bridging the gap between R&D, innovation, global quality, and accessibility, and primarily in the context of the spine community in India. Some of the historic problems ailing the spine community in India have been global quality means least accessibility. High accessibility means manufacturing of cheap copies of globally established multinational brands. No investment in R&D, poor instrumentation, and raw material procurement from non-standardized sources. The root cause of all of this has been our entire ecosystem, including us as the industry, where pricing has been the only strategic metric to gain market share and not R&D, innovation, and quality control. The surgeon hospital focus has been primarily historically on cheap pricing with high MRPs. Patient economics is, of course, the reality of the day. The regulatory bodies have been indifferent to regulation, and media, government, and public has a populist thought process with wanting to have free healthcare in everything. This is in stark contrast to the achievements that have been there in the space technology, where India is a global hub for satellite launches. We have had successful Mars orbit missions, and we have successfully discovered water on the moon. So the question is there light at the end of the tunnel? What are we as a company trying to do to make this change and to walk the talk in terms of delivering the change? So India's Medical Technologies, right from its very inception, has had a very strong R&D innovation, which has been the cornerstone of our company, with the vision of ideating, innovating, and investing in India for healing spinal disorders, not just in India, but across the world and across the globe. We are proud to announce that we became the first ever spine implants company in India to have received the coveted US FDA 510(k) clearance for our products. The second testament to our intent and to our effort is the intellectual portfolio that we have had. We have multiple patents, US patents, India patents, and we have patents pending in Europe as well as in Japan. We are bridging the gap of high quality and accessibility through extensive R&D and delivering highly engineered products to our customers, and at the same time through global access. We have a state-of-the-art manufacturing facility with a globally established supply chain, and we are already selling and marketing our products in the United States and all across India. So I request you to visit our booth at this ASSICON 2021 conference to see and review all our products that we have to offer to heal spine pain and disorders all across the world, and request you to please give your feedback as well. Some of our highlights for this conference are our PINAC Accura lumbar stabilization system, which is a pediatric screw with adult load-bearing capacity with the lowest profile screw head and the lowest tightening torque, primarily for benefit to the osteoporotic patient. We have a very unique and innovative lumbar interbody spacer system with the first of its kind end-plate specific geometry derived from CT scan data from hundreds of patients with the goal of improving sagittal balance. We also have a titanium spacer with a specialized surface treatment to improve osseointegration and prevent pseudoarthrosis. On the cervical plate front, our Setu Sealing anterior cervical plate offers the best imaging profile with minimum metal and maximum strength. And one of our key launches for this conference is our PINAC occipitocervical thoracic system, cervical lateral mass and pedicle screw system with a very low profile 3.5 and 4.0 versatile rod system and very unique innovative reduction instrumentation which can help solve problems related to complex cervical deformities. With this, I end my presentation and I thank you very much. Thank the ASSICON ASSI committee for giving us the chance and opportunity to present at this conference. I request you all to please stop at the booth and give your feedback. Please use the email addresses to get in touch with us or the phone numbers listed over here to get in touch with us for any inquiry and for any feedback. Thank you very much and best wishes for ASSICON 2021.
Thank you, Aditya. I must say that we feel proud that a company from India is doing, competing at the world level and doing so good. So congratulations to you for the same. I just heard that you will be launching the occipitocervical system. If you could just, talk about what's good with this system, how is it different from the ones which are existing? And you talked about some reduction system as well. So if you could just tell us about it.
Thank you very much, Dr. Nanda, and thanks for this opportunity. Our occipitocervical thoracic system, one of the key points is having a very low profile head and having a dual fixation system in terms of you can use a 3.5 as well as a 4 mm rod in terms of more unstable occipitocervical constructs. That is one of the key points. So it's not just a single diameter rod system, it's a dual diameter rod system. It has all the provisions of having tapered rods, so you can connect from a 3.5 to 5.5. You can go from a 3.5 to 4.0 system, and you can connect from 3.5 to 5.5 to a pedicle screw system as well. At the same time, you can use 4 mm diameter screws in the upper thoracic spine and without changing the rod profile. So overall, where the space is low, you can use our cervicothoracic system very efficiently. On the reduction front, there are certain complex deformities in the cervical and occipitocervical region where we have given very low profile reducers that we have made, which are, I was very much impressed by the MESA crickets that I saw in the earlier presentation. So kind of, deriving from that as to what the importance of low profile instrumentation is, where the space is tight. So we have extremely low profile reducers that we have introduced, which are very unique in the cervicothoracic space compared to what is available on the market, which will help you to satisfy and solve complex deformities. So those are the three key points that we are basically launching our product system with in terms of features and benefits.
Wow, that does sound exciting. And correct me if I am wrong. Is your the only system which is now available with a 4.0 rod in a cervical system in India as of now, or are there other systems which offer this rod?
As far as I know, there may be one another system that is available, but primarily it is all a 3.5 systems that are available. So ours is one of the unique ones. That is available. And
you mean to say that we can connect a occipital plate, or we can connect an all lateral mass system with a 4.0 rod as well with the same screw?
That is correct. That is correct.
I also wanted to know, sometimes, we have this problem of when we put lateral masses and combine with a C7 pedicle, or we combine with a C5 pedicle, then there's a lot of offset which happens between these screws, and rod alignment becomes a huge issue. So do you have any lateral offset connectors also available option right now, or is it in the pipeline?
No, we already have those. So we have a 3.5 to 4.0 connector. So for example, if you want to maintain a less stiff rod at the top, so you can connect from 3.5 to going to a 4.0 rod at the upper thoracic level, or we have a 3.5 to 5.5 rod connector as well. So we have lateral connectors, wedding bands, basically.
Okay, so these are rod-to-rod connectors, which I was talking about, from a screw to a rod, lateral offset connection. Is that available?
Yes, so that is in the pipeline. That will be coming in the next couple months.
All right, I think that sounds exciting, and we'll love to try out your reduction system.
Can I just ask him a couple of questions? Sir. Yeah.
Yes, sir.
So I think very, very impressive, Aditya, what you have said, all of which is very true, but it is our market which governs in India. It is the financial considerations all the time, and unfortunately, we have not been able to come out of it. Mm-hmm. Now, based on these same financial considerations, how can we do a good titanium wiring? We've been using in India hard shield rectangles with sublaminar wires, which are stainless steel. Now, the reason why we have not gone on to use titanium screw and hard shield is becoming also less popular is because it is not MRI compatible, being stainless steel. Mm-hmm. Can you make now with modern technology and all this good titanium wires which would function well even on bending and tightening?
Sure. So as you rightly said, the market has not been there, or it has started reducing. That is why they are not available. But as far as technology is concerned and making a great quality product and having it accessible to a larger population, we are there in terms of technology and business operations, where we can make such a titanium wiring system, which will be imaging friendly.
Because there are cable systems available, but those cables are extremely expensive. And majority of the time when we tend to use these are patients who are extremely poor. So it really doesn't match up. So that is something of a challenge. Anyway, good luck with your innovations. And I'm sure that we see a very bright horizon for your company in the future.
Thank you very much, Dr. Zaveri. Thank you very much for your support. Bye-bye. Thanks, Dr. Nanda.
Thank you, Aditya. Thank you for being here. So we move on to the last lecture of this session, and I'm going to invite Mr. Chandraketu for the same lecture. He is going to be speaking on TerryFrac Solo, and he is representing Intas Inara. So can you please put up slides of Chandraketu, and then we can start.
Hello, everyone. I am Chandraketu, representing Team TerryFrac from Intas. As you all know, innovation is the key for driving growth. So has been the journey for TerryFrac in last 10 years. The growth of TerryFrac has been driven by innovation. TerryFrac was launched with a dedicated task force 10 years ago, and we have been building TerryFrac in fragility fracture hearing. Our promotion has always been based on science. We have been offering quality cold chain to your patients with a unique packaging which has bagged the Best Packaging Award in 2012. TerryFrac has been the #1 TerryFrac brand of India since 2012 because of its patient-centric approach. Today, after 10 years, Intas, in collaboration with Copernicus, launches TerryFrac Solo, the first time in India lateral trigger PTH disposable pen device. TerryFrac Solo comes in collaboration with Copernicus, which is a leading pen device manufacturing company of the world. Copernicus specializes in pen device manufacturing. It has 10 years of expertise in pen manufacturing. The pen designs of Copernicus are focused on safety and convenience of patients. Copernicus is proud owner of 36 patented delivery devices and has global presence across 5 continents. Copernicus is manufacturing Teriflex Solo using world-class manufacturing process which is adhering to all manufacturing international guidelines. Teriflex Solo is specifically designed to teriparatide delivery. Teriflex Solo offers packing par excellence as it comes in shock-proof packing in 600 micron tray thickness, which ensures minimal chances of any damage during transport. Teriflex Solo has ergonomic design and has aesthetic looks. Teriflex Solo is small in size and easy to carry. The pen thickness of Teriflex Solo is designed for comfortable grip. The size and shape of Teriflex Solo is tested for 24 months for human experience. Teriflex Solo, the cartridge is pre-assembled and preloaded. It is a disposable PTH pen device and contains 600 microgram of teriparatide. Teriflex Solo offers accurate dosing with no risk of air bubble and is an auto-priming pen, hence no priming is required for your patients. Teriflex Solo offers transparent cartridge holder for easy view of the clarity of the solution. Teriflex Solo cartridge is pre-assembled at Intas Biopharma plant on a fully automated assembly machine imported from Poland. Teriflex Solo offers fixed dose dialer. The fixed dial in Teriflex Solo offers accurate 20 microgram dosing every time. The laser printing in the dialing window ensures clear visibility of the dose dialed with no confusion for your geriatric patients about dose dialing. The fixed dose dialer in Teriflex Solo is single rotation, smooth clockwise dialing, and is easy to operate for your geriatric patients. Human trials confirm ease of dialing experienced by 89% of patients. Teriflex Solo offers world's first and only teriparatide pen device with a dose counter window. That means after every dose, the pen shows the number of doses left, which means your geriatric patients can plan repurchase in advance. The dose counter in Teriflex Solo reduces the chances of missed dose, ensures therapy continuity, enhanced therapy compliance, and hence better clinical outcomes. Teriflex Solo is world's first and only teriparatide pen device with an ergonomic lateral trigger, which offers better grip as the mode of holding is similar to natural way of hand gripping any cylindrical item, which ensures better stability and hence reduced damage to needle and prevents damage to the skin while injecting. Teriflex Solo offers world's first and only teriparatide pen device with an ergonomic trigger, which shortens the thumb to skin distance to just 93 mm, which is 36% shorter than top push button pens. Teriflex Solo is easy to hold, easy to inject, and easier in handling for your geriatric patients. Teriflex Solo offers spring-assisted lateral trigger, which requires 87% lesser push force to inject as compared to manual pens. The spring-assisted lateral trigger in Teriflex Solo requires only initial push to ensure constant drug flow and uniform drug distribution, and hence Teriflex Solo offers less painful injection experience with reduced soreness at the site of injection. Teriflex Solo is delivered in thermodynamically tested cold chain to your patients. It comes with 3 ice packs, which is complementary with every pen. Your patient has to use 32 gauge BD needle to inject Terrifrac Solo. For zero contact patient demo, we have incorporated the QR code and YouTube URL link in the package insert of Terrifrac Solo so that your patient can view the demonstration online. This helps to avoid physical demo to your patients, which is very important during these current pandemic times. Let me take you through the 8 unique benefits of Terrifrac Solo once again. Terrifrac Solo comes in shock-proof packing, which prevents pen damage. It is ergonomically designed pen for better grip. It is a pre-filled pen device, hence no priming is required. It offers fixed dose dialer, hence accurate dosing. It offers dose counter, hence there is no chance of missed dose. Lateral trigger in Terrifrac Solo ensures lesser push force, better stability while injecting, and hence less painful injection experience. Thank you.
Thank you, Mr. Chandraketu. So it's good to see that you have come up with this device, because personally I have seen problems in my patients regarding they didn't come to know that the injection is finishing, and they have been skipping the doses. Also, the problem of adjusting the dose while you dial on the pen, as are available in different companies. There has been confusions and people have been underdosing or overdosing. So I think it's a very good launch from your side, and it will be well appreciated by the medical fraternity. One of the apprehensions as clinicians, which we always have, is, the product maybe being at a state-of-the-art facility. But then once the product is out of the company, and the cold chain maintenance may be questionable in terms of how it is transported when it is given to the stockist. And we know that the potency of this injection is very much dependent on cold chain maintenance. So could you, give us a couple of sentences about how you guys are, quality checking and making sure that even your smallest town stockist does not, meddle with the cold chain? So can we be assured of that?
Yes, sir. Sure, sir. Am I audible, sir?
Yeah.
Yeah. Sir, actually, right from the manufacturing unit, that is the biopharma plant at Ahmedabad, sir, we have a temperature equilibrium monitoring system. Now, that is set to 2 to 8 degrees Celsius, and any variance is computer monitored, online monitored every time, 24 hours and 7 days a week. So at the plant level, there is no chance that it is varying the temperature. From the plant to the warehouses, and from warehouses to the stockist, there are special vehicles which are cold chain vehicles, which carry the drug to the stockist, to the wholesaler. We have a different set of wholesalers and stockists who have to submit a cold chain protocol certificate that they have a proper facilities for maintaining these cold chain products. And periodically we review them, and our field staff has to go and check certain parameters. There is a set format for that in which they have to check, and they have to submit this format every 6 months odd to the head office so that the cold chain is working properly. And from the stockist to the patient, as I have shared in my presentation also, we have a cold chain bag with a thick thermocol wall with 3 complementary ice pack. It goes to every patient as complementary. So from 2 to 8 degrees, this is a world class. We have been awarded and rewarded nationally also for this cold chain which we have been providing. And I assure you, sir, that on behalf of our Terrifrac team, that we maintain this cold chain. We take it very seriously, and that is why we request of the medical fraternity also to trust to purchase it from us only. And there are currently online platforms who are offering these biologics, and we have no tie-up with any of these online platforms, so we cannot ensure any cold chain if the patient is purchasing online.
Sure. So Chandraketu, point well taken, and we are glad to know that you are doing such international level of cold chain maintenance, and probably people should be directly contacting you guys to get their products. The other part I wanted to ask was this solo, Terifrac solo. Are you going to charge the patients this pen? And if you're going to charge, what are going to be the damages for the patient for this?
So the pen comes free with the drug because the cartridge is pre-filled inside the pen. So every time a patient has to purchase a new dose, he gets the entire pen.
And does that change the price of the current pricing of Terifrac?
So the current pen, if a patient purchases a single cartridges, it is around about 4,650 rupees plus the pen cost, which is say 1,100 rupees to the patient. So currently, which we have made free for every new patient, but the cost of Terifrac Solo is just 4,950, which is 350 rupees extra, with the pen coming free with every dose. So it is around about only 300 rupees extra, which they have to pay for such a world-class pen device. So it is not very expensive.
Ankur, can I ask one question?
Yes, please go ahead, Guru.
Actually, I just wanted to know, because you have this solo device now, which is like a pre-filled cartridge with a pre-filled pen. Have you thought any time to have a temperature cold storage maintenance indicator in this pen? Actually, that will help it in very.
Yes, sir. Yes, sir. Let me share with you when we transfer the drug from our factory to the wholesalers in the vehicle, there is a data logger, temperature data logger. Now, this temperature data logger is electronically controlled, and this can be attached to the laptop and seen that every hour what has been the temperature of the container in which it has been transported. So this data logger is available with the wholesaler, where it is temperature data logger can be accessed and seen that what has been the temperature throughout the storage time of this drug. As regards transfer from wholesaler to the patient, we are certainly not using it currently, because we supply it as on the request of the patient. So we are not using there. But the suggestion well taken, sir, if it can be thought of.
Chandraketu, thank you very much. I'm Dr. Gautam Zaveri.
Yes, sir. I know you.
And thank you very much for your lovely presentation and the efforts you all are making to improve the ease of delivery to the patients.
Yes, sir.
We know we have at ASSI, we have always been extremely close to Intas. They have always supported us in all our activities. At least I know for the last 5-6 years since I've been actively involved. Javed, Jagrup ji, all these people have been extremely close to us, and I thank again Intas for being with us all the time. I have a question in the sense, what is the innovation coming up? I've read about something about intranasal sprays for parathyroid hormone. Are you aware of anything like that? Because that would definitely improve the compatibility of the patient in the sense patient would definitely be happier, because right now taking an injection for 2 years approximately is a big challenge for them. The second question is that what is the latest research showing? Because the only research which showed something about tumors was in dogs at 3 years. There has never been any research to show that there have been tumors in human beings. So, yes, if possible, I would love to give this drug even for a longer period of time if patients are compliant. However, at present, the advisory is that you restrict it to 2 years. So what is there on this front?
Sir, as regards your first question, that is development of PTH nasal spray. At this point of time, on behalf of Intas, I'm unfortunately I have to admit that we are not have got any development going on that front. Our latest, very well know, sir, we have recently launched about 1.5 years back denosumab, which was our latest entry in the osteoporosis management field. But in the coming time, we are not. I have not been informed by our research and development team that we have been working on those lines. Now, coming to the second question, sir, the guidelines have not changed yet till date also of using it or using teriparatide beyond 24 months. They still stand at 24 months, the maximum duration. But I have got several papers, clinical trials, data, done individually by centers and hospitals and doctors who have used it beyond 24 months also. Now, the other thing which I would like to add here, sir, after the introduction of denosumab in the market, there has been a couple of studies which have come, international studies with decent amount of patient count, which say that alternate use of teriparatide with denosumab, like 6 months of teriparatide therapy followed by 2 years of denosumab therapy followed by again 6 months of teriparatide therapy, or prolonging that duration of 24 months to some years. Those studies have come up, but definitely at this point of time, I can say that there is no such guideline issued by FDA or European guidelines which suggest that we can use it beyond 24 months.
Right. Thank you, Chandraketu. There are a lot of questions for you still. I have one question, one advice to you and a request also. And
Yes,
that
sir.
is that you need to market this drug very aggressively with the pulmonologist, with the nephrologist, and with the hepatologist. A lot of patients who come to us with very bad osteoporotic fractures are patients on steroids put by the pulmonologist, patients with chronic kidney disease or chronic liver disease. These people do not start anti-osteoporotic agents at all. And we know that in this group of patients, teriparatide is a far better drug than either denosumab or any bisphosphonates. So you need to promote, you need to do awareness. And if you need, most spine surgeons would be very happy to come and speak to this group of people, because we are facing more, and now patients are living longer. Liver transplant patients, kidney transplant patients are coming, and they come with horrible problems which we cannot solve unless we do some of this, more of this. Okay. Thank you very much.
I got the point, sir, and we'll definitely take it up in because fortunately we are going to start a new financial year from April, and it can be a strategic initiative from our side, sir. Thank you so much. I must communicate my deepest thanks to Dr. Ankur Nanda as well as the ASSICON Society for providing us this opportunity to launch Terifrac Solo. And we will be more than happy to be assisting or to be partnering you in any further ventures that ASSICON does. Thank you so much, sir.
Thank you, Dr. Chandraketu. So with the permission of Dr. Gautam, we'll call this session to an end. But this session is ending for, starting a very, very dynamic session, which we are going to start. Just for everybody's knowledge and update, the next session is going to start at 6 o'clock in the evening. It's going to start with an inauguration, which is going to be, hosted by myself, and is going to be attended by the president of Argentine Spine Society, president of German Spine Society, Korean Spine Society, and the chief guest is going to be the Director General of Health Services, Dr. Sunil. Please remember that this session is in the special sessions hall, not in Hall A and Hall B. So please log into the special sessions hall, which will be immediately followed by the Argentine Spine Society meeting. And we'll be ending with Meet the Legend session, where stalwarts like Dr. John Lonstein, Dr. Lawrence Lenke, and our own Dr. VTI sir will be talking to you one-to-one and sharing their life's experiences. It's one session not to miss. So with this, I'd like to call an end to this session. Dr. Gautam sir, any closing remarks?
No, I'd like to thank both Pankaj and Ankur for hosting this session, and specifically this session with industry. I'm sure all of us learned a lot from the industry perspective also, as much as we did know about medical knowledge and all. So the entire morning has been extremely useful and fruitful, and I hope everybody has enjoyed as much as I have. So as Ankur mentioned, in the evening, we meet you all on the special sessions platform for a fantastic academic show. Look forward to seeing you in the evening. Thank you.
Thank you, sir. Thank you, everybody.